So we are going to begin with an update on recommendations of the 2020 and 2021 special committees of the Kansas Mental Health Modernization and Reform. We had requested this because during those special committees, there were some recommendations that were made, and Andy's here, and he's going to fill us in on some updates regarding those recommendations. Thank you for being here, Andy.
Yeah, Andy Brown, I'm the Commissioner for Behavioral Health Services at ks, and I'm happy to present this. We do have this is, at this point, it's kind of like a 3-year tracker of the progress that's been made on these Mental Health Modernization Reform Committee recommendations. And at this point, a lot of these have either been implemented or funded and action taken by the legislature. So there's a lot of them that are going to be marked completed and or in progress. And oftentimes the in progress means that we've already taken some steps forward and things are just in the process of completing the implementation. And so I'll go through these hopefully kind of quickly, but if there's anything that anybody wants to talk about or has questions, feel free to interrupt and just let me know. So the first recommendation was around the clinical supervision hours, and this was a recommendation to reduce the number of clinical supervision hours required at the master's level for licensure at the BSRB. That was passed by the legislature, and it's been mostly implemented by the BSRB at this point, so that one we marked as completed. 1.2, this one was around the legislative post-audit review for behavioral health recipients of the National Health Services Corps. My understanding right now is that this is still being researched about funding the study. So there is still an in-progress mark on this one. For 1.3, this is the provider MAT
Andy,
training. Yep.
Do you know what I think I'm going to do is, because there's several of these, we're just going to take a second with each one, and we have plenty of time to give an opportunity for the panel or for the committee to take a look at this and then ask any questions.
Sure.
Okay?
Yep.
I do have a question, and that is, it says it was revised in 2021. This is 2023, but you say we're still looking at how to fund a survey? Is that what I...
Yeah, and by that I mean I don't think that the funding has been provided to KDHE in order to complete the study at this point. And there was a significant amount this was kind of a recommendation where there was a later recommendation that was then combined, and this was rewritten to be this red text that's on here. And so right now, my understanding is that there's a request to the legislative budget committees to include a proviso in the budget for the study, and I'm not sure that that's happened yet.
And can you give us an estimate of what we're talking about here?
I do not have a dollar amount, no.
Committee, any other questions? Seeing none, we'll move on to number 3.
Okay, so this one is for the Medicaid-assisted treatment for opioid use. And this is really to provide training for the providers and to make sure that our prescribers have federally required training to prescribe those particular drugs for like buprenorphine, those sorts of things. We do feel like there's been enough progress on this made to consider it completed, and there's information for free provider training that's available on the government website now. And we've been able to promote that through things like KU's ECHO program and stuff like that over the years. So we feel pretty confident that that's readily available and are promoting that to our provider networks.
Questions, committee? Number 3. And can you give us an idea of the subscribers, what percentage of them have completed this training?
I'd probably defer that to KDHE at a later opportunity, but I think that what we're seeing is that for waiver prescribers, we're getting closer to having sort of a statewide coverage where there's a prescriber within about 30 minutes of where the patients are within the Medicaid system.
And would a patient know if the prescriber had had this training?
Yeah, it's a federal requirement to have the training in order to provide the prescription.
I see.
Yeah.
Okay, so you're saying within 30 minutes, they should be able to get their prescription?
Yeah.
Is that what I hear you saying?
Yeah, so
Okay.
the MCO network adequacy standards are what we're trying to meet with that, and I think we've been successful in getting it down to the 30-mile, 30-minute range.
Okay, and we're ready for number 4.
Okay. So 1.4 is the workforce investment plan. We marked this one as in progress. Last year, there was a significant amount of legislation that was passed that created new levels of behavioral health professionals that can help fill workforce positions. So that has passed. There's many other parts of 1.4 that still need action. And I think that we are going to probably be presenting some options this coming session that might help us make progress on those recommendations.
Committee, do we have questions over number 4? Representative Briggs.
Apologize, getting rid of a button. Thank you for the report on the associate level practitioner role. Can you kind of give me a breakdown of what that might be?
Yeah, so most of our licensed positions require either a BA or a master's degree. So that having the associate's level licensure basically allows for somebody to begin practice at a lower level under supervision from either a bachelor or master's level position.
Would they be able to eventually achieve a bachelor's and work on a bachelor's, or is there a time element that they may not need the bachelor's with, say, 5 years or anything in that?
I don't want to speak for the BSRB, but I believe that it's intended to be a stair step. So it's an opportunity to join the workforce and start working in the field before achieving their bachelor's or master's level.
Okay, thank you for that clarification.
Could we just clarify what's in purple here at the end? So yes, last year, significant legislation was passed that created new levels of behavioral health. But then you go on to say that many of the objectives remain incomplete.
Yeah.
Are those in any way in conflict? They should be working in tandem. Could you explain that to us?
Yeah, I don't believe they're in conflict. It's just that we've put a lot of recommendations into one recommendation, right? And so there's, just as an example, there's, a requirement or a recommendation for the state to establish at a university in Kansas a partnership to develop a comprehensive investment plan. That hasn't been achieved yet. It's just an example.
Committee, other questions regarding number 4? Yes, Representative Blex.
Thank you for a second time. On that last sentence, including diversity related to race, ethnicity, and LGBT plus identity, I recall in the Health Committee with the BSRB, we took that out of a bill that was in there, and now is to see that back. Is that something that was carryover from, or is this something additionally new?
Nothing in this document is new. Everything here is from the Mental Health Modernization Reform Committees that met 2 years ago.
Okay. All right, thank you.
Yeah.
Thank you. Let's move on to number 5.
All right. So 1.5 is the family engagement practices. This recommendation we marked as completed. These changes have been made to the state Medicaid plan, and we also added a new parent peer support program that was started this past year. So we feel like we've achieved this recommendation goal.
Committee, any questions regarding number 5 or comments? Seeing none, you may continue to number 6.
Okay. So number 6 is the CCBHC model. Again, this is something that we've marked as completed. We do still have 6 CMHCs to get across the finish line, but all of the required work from KDHE and KDADS to allow that to occur has happened.
Trying to do the math, so I understood that yesterday we had 19, is that correct?
I believe it's 20.
We had 20, okay, I thought it was stated 19. So that would make the numbers would work then. I was thinking there was 7 missing.
Yep.
All right, thank you. Committee questions on number 6? Seeing none, you may go on to number 7.
Okay. So 2.2 is around addressing the inpatient capacity. This is another one that received a revision in the second committee. And this is something that we've marked as completed. That's largely because both Spark and the legislature have allocated resources to expand our bed capacity. KDAS has initiated the contract for site development in South Central Kansas, and the SIA program has been successful in helping divert patients and continues to expand. So we've marked that as completed. We feel like we're making good progress on that goal.
Committee, do we have any questions regarding this? You may continue to number 8.
Okay. Number 8 is a reimbursement rate increase in review. This was revised in 21 to add all providers of behavioral health services. In terms of an update, we still believe that this is in progress, and that's because it calls for an increase of 10 to 15% of the reimbursement rates. We haven't had that level of investment at this time. Again, I think it comes down to it's a funding issue to implement that on a long-term basis. But we have increased the rates somewhat. I believe there was a 2% across the board increase 2 years ago. And we've been working to increase rates where we have the opportunity to make some ground on ones that have had longer term, but those have not been across the board increases.
Committee, any questions on number 8? Yes, Representative Ballard.
Thank you, Madam Chair. All right, we said we have made some progress. Who are we actually looking at? Like, is it Missouri, Iowa, Nebraska, our regionals in terms of rates that they have?
No, this was just to increase the rates here in Kansas by 10 to 15%.
Just 10%.
And I said 2%. I think it was actually a 4% increase.
Okay, are we woefully low, or are we in the middle?
I don't have a rate study for where we are compared to our neighboring states, and that's something we could probably work with KLRD on to get for you.
Okay. All right, thank you, Madam Chair.
Would you please? Yes, Senator McGinn.
Thank you, Madam Chair. When it says for all providers of behavioral health services, will that include hospitals?
I believe it would include anybody that's able to build the codes, yes.
So it's a code. It'll go down to the code. Thank you.
Committee, additional questions? I concur with Representative Ballard's request. I think it would be good for us to know. based upon the codes. And I realize there are 14,000 codes. Not all of those, of course, are behavioral health. And you cannot take it code by code by code, but just on a general basis, that would be helpful for us to know. Please move on to number 9.
All right. So 2.4 is around suicide prevention. We did mark this one completed. That's largely because we were able to add to the agency budget a $1 million suicide prevention fund. And that has been used to implement many of the plan's objectives and strategies. I'm going to do a presentation on that following this. But KDAS was also successful in applying for a federal GLS grant, which is the Garrett Lee Smith grant, and I'll talk about that a little bit more later in the next presentation.
Senator McGinn has a question.
Thank you, Madam Chair. And I'm sure maybe this will come up in your next presentation, and I'm a little too early, but I guess just increased money to me is not what success is on suicide prevention. I hope that you'll have the numbers about what is trending right now on that. So more money, still more suicides.
Yeah.
That's not success.
Yeah,
So.
and there is, there are I think 4 or maybe 5 presenters that are presenting about suicide prevention today, and I believe KDHE is going to present statistical information, and I think KHI is going to present some information about trends.
Okay. Thank you.
Committee, other questions regarding number 9? I, too, look forward to the additional presentations today. And we will move to number 10.
All right, number 10 is around the Problem Gambling and Addictions Fund. This is another one that we've marked as completed. And that's because we were able to increase the proportion of money in the PGAF that's applied to treatment. And we're going to continue to work on that as a goal, but we've made progress on that over the last couple of years, both with the sports betting bill and language that was attached to that, as well as changes that the governor made in the governor's budget.
Committee questions regarding number 10? I have just a comment. Do we have, I guess it's a question, but, and then a comment. Do we have data, or we should have data, how many people have participated in this program? Because we hear we have X amount of dollars allocated, which makes you wonder how many people are we using these dollars to assist? And is that enough? Is that not enough? And we just expanded gambling in our state.
Yep.
And so how many more people may be having a problem? Can you get that information to us?
Yeah, we can certainly pull that later.
Thank you. And we have a question from Representative Carpenter.
So on this $8 million roughly, and then, so we have a couple of grants out there. We're not using the money that's coming in there for these programs though, right?
Yeah, so there's about 8 million that's in there, and right now we've got I think in the neighborhood of about 4.5 to 5 of that's going to support Medicaid services for substance abuse and for problem gambling. We do have dollars that are going out to our task forces, as well as money for a statewide campaign that's been added. We've doubled the size of our problem gambling team, so we're looking to fill additional positions for that. And we've recently brought in a new program manager for that program. So I'm expecting to see quite a bit of activity, but indeed, the funds, there are still a significant portion of those that are going to support it, substance use as well.
Which is not problem gambling.
Right, but
Okay.
it's one of the intended uses of the fund.
I know,
Yep.
but we're not using it for that because.
Right.
Okay, just so we're clear. Thank you.
Thank you for sharing that, Representative Carpenter. I was not aware. Please continue to number 11.
Number 11 is to expand the Medicaid Health Intervention Team Program. Yesterday, you heard a lot about that, especially during the conversation in the afternoon. We have marked this one as in progress. It has been expanded to, I think we're up to 60 or so schools. And I don't have all the information about how many schools are in each district and all that kind of stuff, but I think you heard yesterday quite a bit of progress on how that's been going.
Committee questions on number 11? And you're right, we heard a lot about that yesterday, very helpful information. Please continue to number 12.
Number 12 is the Crisis Intervention Centers. We've marked this one as completed. The idea here was to utilize state funds to support the expansion of crisis intervention centers. And we've successfully opened one in Douglas County. Our regulations have passed through the AG's office, and we're hoping those will be available for public comment soon. And then we'll be able to continue to expand those out further. We were also included in our agency budget requests. There's a line item for $10 million to help expand those programs around the state. So we're anticipating that we'll be able to make good progress on that, and there isn't any additional action needed by the legislature.
Representative Landwehr.
Thank you. Does any of this, this crisis services have to do with the 988 requirements across the state for,
Yeah,
is that what it's tied to?
well, there's crisis requirements both for the CCBHCs as well as 988. The intention is to try to build out a what's referred to as a crisis now model, which gives people a place to call when they're in a crisis, somebody to respond to them in person when they're in a crisis, and then also a place to go in their community if they're in crisis. So that's our goal, is to try to get that built out around the state.
So if a call comes in a 988 and a crisis unit needs to move, these here, this is where they would be routed to, correct?
Yeah, if they weren't able to successfully resolve the crisis either on the phone or in the person's home or community, then the crisis center would be the next step.
And if I recall correctly, is it an hour that we have to have service, within an hour that we have to have services?
So right now, the national standard is 1 hour for
Right.
urban areas, 2 hours for rural areas.
2 hours, okay.
Yep,
I got it backwards.
it's okay.
Representative Ballard.
Thank you, Madam Chair. I don't have a question, but, you know, I just want you to know that our crisis center is open in Lawrence, and we were anticipating that happen, and there were delays and everything else, but it is up and running. And we are sticking to that 1 hour, because I'm on the Burt Nash board, and we were discussing that along those areas. But it is nice to have it up and running, and I can remember many years ago when it was first proposed, so, and it's actually there.
Representative Landwehr.
This would be actually for Representative Ballard. You're off the hook, Andy. So why does it take an hour in a urban area? Why could it?
Well, it could.
I'm just asking from your experience. I'm not trying to criticize your.
No. I think from that standpoint, it could be at the time that the person who's on call may not be available.
Trying to, okay.
But then they have a backup to that person. But it seems that, you know, whenever you need something, it's right at the time that somebody else is busy or whatever. But I think that basically, the goal is to go quicker than an hour.
Right.
But it's not supposed to be any longer, am I correct?
Yep.
Than an hour. So that's why they have a backup to the person who's on call at that particular time, especially if it's a late hour.
So kind of like moving a voluntary fire department.
I think so.
Yeah, all right, thank you.
Representative Carpenter has a question, but before I go to him, I just want to mention that our next speakers will be from the 988 Crisis Center in Douglas County, and I did have an opportunity this week to go and tour that facility. Representative Carpenter.
Thank you, Madam Chair. So we have one crisis center that's opened. How many are we looking at?
So we've got one crisis intervention center in Douglas County. We have multiple crisis stabilization units around the state that have been funded through the lottery vending machine funds. And we're working with those communities to see about whether or not they want to move when the new regulations come out to a CIC license. And that the difference in that license is what allows for the involuntary holds and for law enforcement to drop a patient off and leave the patient there.
So we have this mark completed. I'm not sure that it's completed. These regulations sometimes take quite a while.
Yeah, we've been working on them for years at this point.
Okay,
Yeah.
so I'm just a little concerned about scratching this off our list and it not being on our radar screen at this point in time, knowing what I know about rules and regs being, so anyway, I'll leave that up to the will of the committee.
Do you have any comments to make on that before we move ahead?
I don't mind changing it to in progress.
All right.
You want me to come back
Committee,
next year?
What is the will of the committee? And do you want to make a motion, Representative Carpenter?
I'd make a motion that we leave that as in progress, just so that we can kind of, it doesn't drop off our radar
I would
screen.
second
A
that,
second
Madam Chair.
from Representative Ballard. Committee, all in favor, say aye.
Aye.
Opposed, same sign. We will move this to incomplete. And we'll move on to number 13.
Number 13 is 3.2, which is the IPS community engagement. IPS is a supported employment program that's evidence-based. We've made it a core part of our CCBHC requirements. And we continue to work to make progress in waiver programs as well. So for the folks that are in the Long-Term Service and Supports Commission, they're also working on supported employment as well as our partners at KDHE. So I've marked this one as completed, but we're happy to take questions on it.
For our listeners on WebEx and in the committee room, could you give us a definition for IPS?
It's individual placements and supports is what the acronym stands for. A supported employment program is basically a program where people who need additional support in seeking jobs and maintaining jobs or maintaining employment have a team of individuals that assist with that.
Questions, committee, over number 13. Representative Carpenter.
Well, ditto on this one. You know, this is never going to be completed. I'm sorry. We've been working on this for years and years and years, and I don't know that we could ever complete supported employment. Just saying.
And your thoughts?
Happy to come back and keep reporting.
Keep it incomplete. In progress.
So is that a motion, Representative Landwehr?
Yes, keep it as in progress.
Representative Landwehr has moved that we keep this as in progress. And do I have a second?
Yes, second.
Representative Ballard. Committee, all in favor, say aye.
Aye.
Opposed, same sign. That has been approved, and we will put this as in progress. You may continue to number 14.
So number 14, I've left as in progress. This is the foster homes. Recommendation was revised in the second year of the committee to include support for families navigating the child welfare and Medicaid programs and continuing investment. We do feel like there's been a lot of work done collaboratively between DCF and KDADS to try to make progress on these issues, but we feel like there's still a lot of work to be done on it.
I see a response from September of 2021. Typically, we see one from 2022. Do we have any response from that? Or is it basically stay the course, same thing?
I believe there is not, I don't know that there's been any updates provided by DCF for it.
Representative Landwehr.
And Andy, you may not be able to answer this, but wasn't, because now I'm trying to go back to, I think, 17 and 18, I think. It was like Families First or something to that effect that was supposed to be helping with this. And we were supposed to be hiring like, what, 80-some plus social workers and all that good stuff, and we're still in progress.
Yeah, well, Family First is operational.
Right.
And I'm at a disadvantage because I don't really have a lot of information about where DCF feels like they're at with this particular recommendation. We're a couple of years into the McIntyre settlement agreement and working on resolving a number of the issues around behavioral health and foster care kids. We've added a lot of information and requirements to our participating agreements with the CMHCs, including time requirements on how quickly they need to be able to receive a foster care child into their services and do their evaluations. We've also been working with them on our MRSS, which is a mobile crisis response for children. That's now been in effect for about 2 years, and we're still working on building that out further. So there's a lot of these recommendations that are, like I said, still ongoing that we're still working on making progress on under that settlement agreement.
I think, Madam Chair, what we need to have is a gathering of all of the programs that we have out there currently in different phases that are supposed to be addressing this. Because I think we're duplicating in some places, and, you could have 10 irons out there, but maybe you only need 5, so you're spinning a lot of wheels. And that's not on you. And I realize that's a question for the secretary, but I think if staff could, help gather that, have the agencies help gather that information, I think that would be very helpful, because we're not looking at the whole picture. We're looking at piece here, piece here, piece here. We need the whole puzzle.
Representative Landwehr, I totally agree, and with the Bob Bethel Committee coming up in October, that could be a perfect opportunity to have that presented to the group.
I'll take that
That's
back.
Okay.
a date certain, Madam Chair. I like that.
All right. Any other questions, committee? You may proceed to 15.
All right, so for 15, we've marked this as completed. This is the community-based liaisons. This was also revised in 21 to include language to expand locations where community-based liaisons are available. And this is to help facilitate connection to treatment and support services upon reentry of individuals from incarceration. So most recently, we've included that in our participating agreements as a requirement for the CMHCs to have a liaison for that role. And they should be available now at all CMHCs across the state and as part of the care coordination model for CCBHCs.
Committee questions about the community-based liaison? Seeing none, you may move to 16.
All right. So 16 is 4.1, which is the 988 Suicide Prevention Lifeline funding. I've marked this as completed. And that's because, again, Senate Bill 19 was passed last year, actually two sessions ago now. And that established a $10 million 988 fund, which went into effect in July last year. So we'll have, more information about that later this morning as part of the suicide prevention discussion. But we do feel like we've accomplished this goal of securing a funding source. And there's a 988 coordinating council that's a part of that Senate bill that will continue to make reports and additional recommendations around funding needs.
Can you tell us who determined the reporting council?
So there's 2 members of the legislature that are appointed, and then the rest of the appointees are appointed by the governor's office.
Thank you. Committee, are there questions on number 16? We'll hear more about it with our next speaker. Yes, Senator McGinn.
Andy, I look at the 10 million and then the discussion of the 988 meeting, that we're making a recommendation to put another 10 million in. So it's still year by year proviso. Is that correct?
No, the Senate Bill 19 established a base of $10 million on an annual basis. And then the way it's worded now, any unused funds are then swept, and it fills back up to $10 million, essentially.
So it is in permanently.
Yes.
Okay, thank you.
Representative Landwehr. So when we say swept, we mean swept back into the general fund?
Yes.
Okay. Any other questions, committee? Representative Landwehr.
More of a comment. And, I think that it's probably going to be possible, because this is still evolving, because we still got to get more crisis units and everything available out there. But if the 988 can have that rollover, that could also decrease and delay for a while of having to come in with any other revenue source.
You may proceed to number 17.
Okay. So number 17 is around early intervention. And this is to work to increase access to early childhood mental health services. We've marked this one as completed. KDHE and KDADS determined that these services were available currently through our EPSDT program, which is under the current CanCare program. So we'll review again when we get our new authority under our next version of CanCare, but right now we believe those services are available through EPDST, and so there isn't a need for us to make a change right now.
Representative Landwehr.
And that acronym stands for?
Yeah, you're going to test me. So
You can get it back to us. Andy.
yeah, I'll happily get back to you on what EPSDT stands for, but there's screening, diagnosis, and training. Treatment is the last three letters, and I think it's. Do you remember what the EP? Early periodic. Is that what we said? Screening, diagnosis, treatment. Yeah. Phone a friend.
Committee, other questions or comments on number 17? We're moving on to 18.
All right. For number 18, this one was also marked completed, and this one's been considered completed for a while, but this was to centralize coordination of behavioral health, including SUD and mental health policy and provider coordination at a cabinet level position, and it was determined that Secretary Howard would be that cabinet position.
Committee questions on number 18? Moving on to 19.
So 19, I've left as in progress. This is around behavioral health prevention. And this is to increase state funds for behavioral health prevention efforts to support additional evidence-based primary prevention and grant opportunities for community prevention activities. We have been repeatedly working on trying to advance that as a goal, but we have not secured any funding yet at this time.
Committee, any questions on number 19? Seeing none, we'll move ahead to 20.
Okay, this one's also in progress. This is for trauma-informed care. This was a new recommendation that was added in 2021. And this was to work with the Governor's Behavioral Health Services Planning Council to convene providers that had implemented trauma-informed practices to make recommendations for a pilot program. And so far, we've established that committee, but we haven't received their recommendations yet.
And this was established in 2022, but we have no recommendations yet?
That's correct.
How often do they meet?
I believe they meet monthly.
They meet monthly, but we don't have any recommendations?
Yeah.
Could we, because it says, yeah, it's in progress, can you please let them know? We would appreciate any of their recommendations.
Yeah, so the council subcommittees usually present their reports in kind of the September to October range, so we should have it fairly soon.
Good to hear. Thank you. Please proceed to number 21.
So for 21, we marked this one as completed. These projects were to really create strategies to address the social isolation that was part of the public health emergency. We feel like we've worked closely with the MCOs as well as KDHE to try to address that issue.
Committee, any questions on number 21? Seeing none, please proceed to 22.
So 22 is to try to normalize behavioral health discussions. I marked this one as completed. We've basically worked with our PIO to make sure that we're presenting positive sort of stories about successes and to try to normalize progress on behavioral health here in the state. So those messages have been going out on social media and other communication channels around the state, and we continue to work on making progress on that. But currently, that model of marketing those seems to be working.
Committee questions or discussions about 22? Seeing none, let's move to 23.
All right. For 23, this is around PRTFs, which is a popular subject. We marked this one as completed because this was to monitor the ongoing work to improve care delivery and expand capacity at the PRTFs. So we've got our monitoring systems in place at this point, and we're continuing to look at additional ways that we can focus on reintegration and discharge planning. And improving communications with schools. So we continue to work on those as issues with both the providers and the MCOs, but there's an ongoing monitoring process that's in place.
Representative Ballard, did you have a question?
Excuse me, it's not on. I'm sorry, I'm not sure that we have reached that point, even though it says that list is down, because I still hear a lot about not having facilities available. So I would suggest that we keep that in progress.
And Representative Ballard, if I may, under recommendations, the request was that they monitor ongoing work to improve care delivery. And so I think he's just trying to say they are monitoring.
So
Not to reach to a certain level, but that they are monitoring.
Yeah, so right now we're making regular reports to Bethel, as well as our internal process is it's a weekly report that we receive. That's a commissioner's level report that goes out to the secretary and the cabinet level folks, as well as to our other commissioners at KDADS.
All right, Madam Chair,
Yes.
but if it says it's completed, how do I know, I'm not going to put we on it, that we will continue to do this along the lines?
Okay.
Completed says it's done and you don't have to do anything else. But I'm thinking we have a lot more that we have to do, but maybe I'm not understanding which way, so please explain it.
Thank you, and correct me if I'm wrong, but when this was set up, the question, we were saying monitor it and report. And so you're monitoring and you are reporting, correct?
Correct.
And so that's what's completed, not that they've met a certain level or anything like that, but that they are monitoring it and reporting it to us.
I'm fine, Madam Chair, thank you.
Thank you, Representative Ballard. Please continue. Oh, I'm sorry. Representative Carpenter has a question.
So on that subject, is there someplace else in here that's going to address PRTFs? You know, I mean, I get it.
Yeah.
We're monitoring. Great. I've been doing that for quite a while. What's the wait list?
So the wait list numbers, like I said, we get a weekly report on that, and I'm happy to share that with you. But we've been presenting the numbers and the the difference in whether they've gone up or down at the Bethel committees now for probably 3 or 4 years.
Probably 120.
I'd definitely say it's somewhere in the neighborhood of 100.
So, you know, I get it that we've met the monitoring requirement, but to me, it still hasn't solved the issue of a wait list for PRTFs.
Yep, agreed.
And I think, if I may, Representative Carpenter and Representative Ballard, when we make our recommendations at the end of the day, that could be part of our recommendation, is to make another that would not just be monitoring, but set certain goals. Yes, Senator McGinn.
I just want to be clear, the wait list is due to unstaffed beds,
That's correct.
and we're going to open more beds with Ember Hope, correct? Ember Hope has completed its licensing. They'll begin serving children in October.
Yeah, that was October 2 years ago.
2 years ago, okay. So they're already serving them. So it's clear back to then, again, what are we going to do about the workforce, right?
Right. Yeah, it's a workforce challenge
So I
for sure.
don't see how it is completed because we have a workforce challenge there. If we're working on workforce challenges in these earlier pages,
Yep.
so.
And again, if I could just state, no, workforce challenge is certainly not completed. But the fact that we ask them to monitor what's going on and report back. So they have been reporting to Bethel. So they have completed that, but we can make another recommendation. Yeah. Yes, Representative Landwehr. Okay, I answered it. We're going to move to question number 20, or item number 24.
All right, so for number 24, this is around the service array. This is another one that was marked completed early for the 2021. But it was determined at that point when we explored options and did our MAT expansion in the block grant services that we were in a position that met this recommendation to expand the service array for MAT services across the state. So just examples of that are, we applied for a 1115 waiver, SED, IMD exclusion, which allows for us to provide MAT services at a more expanded provider opportunity through Medicaid. We were also able to add policy language to our uninsured population network, the providers that we have through our ASO, which is Carillon. So we're using our federal block grant funds as well as our state uninsured dollars to help expand our MAT provision. And then we also added policy which allows for mobile MAT services, and during the public health emergency, we also expanded our opportunities for take-homes.
Committee questions or comments? Representative Carpenter.
So I'll bite MAT. I know.
It's the Medicaid medication-assisted treatment for
Okay.
opioid use disorders.
Very good. Thank you for that.
Additional questions or comments, committee? We'll move to number 25.
Okay. Number 25 is 5.3, which is related to frontline capacity. This one received another fairly significant revision in 2021. And this was to fully fund a statewide psychiatric access program that includes specialty teams in order to support healthcare providers across the lifespan. So this was a continuation of what we refer to as sort of PPW, or pregnant postpartum women and pediatric programs. This is still an ongoing or in progress effort. KDHE has been working with the University of Kansas to make progress on this. And I believe they've also established a project in Wichita at this point. But it's an ongoing effort, and they did receive additional grant funding for the next, I think, 3 years. But this is something that we'd really like to see state funding support for, and they have not, KDHE hasn't been able to get that added to their budget yet.
Committee questions, comments? Number 25. Moving to number 26.
So number 26, we also left as in progress. This is around expanding supported housing programs, as well as the SOAR program, which is designed to help people get faster access to disability benefits at the federal level. We're continuing at KDADS to work on supporting local community supported housing programs. Additional funding is needed to expand from our pilot projects to more statewide efforts. But currently, we're working with KDHE to expand the role of social determinants of health in the next wave of CanCare, which would include housing programs. And we're also looking to make sure that we're accessing as much federal funds as possible for those programs.
Questions, committee? Moving to 27.
For 27, we've marked this one as completed. This was another one that received an early completion back in 21. But this was to build awareness and responsiveness to the behavioral health needs and risks of domestic violence survivors. And DCF administers a grant that helps provide these services. And they also have a contract with ks.gov where they're doing virtual training.
Questions, committee? Moving on to 28.
28 was 6.2, which was for parent peer support. We marked this one as completed. This program has been implemented within CanCare just within the last year. And we're currently working on building up that workforce and program around the state.
Questions? Number 29.
Number 29 is for crossover youth. This is 6.3. And this was to continue developmental linkages between the behavioral health system, juvenile justice, and child welfare. I've marked this one as completed. And that's largely because DCF has been fulfilling that role of making sure that there's coordination between the various state agencies that are working on those goals with that population.
Questions on 29? Moving to 30.
So for 30, this is 6.4, which is the IDD waiver expansion. This recommendation I marked as in progress. The recommendation itself was to fully fund the IDD waiver and expand IDD waiver services. That continues to be a recommendation from advocates. We received that just a couple of weeks ago when we were working on our agency budget enhancements. There have been increases in the reimbursement rates for the IDD waiver in the last 2 fiscal years. However, funding to eliminate the waiting list has not yet been approved. There is a current study that's going on the wait list itself to help us kind of determine what the fiscal impact of doing that might be. But there's a large number of individuals that are on that wait list, and so expanding it would be a significant investment.
Committee, I would just mention during our during the IDD waiver committee, I felt we made some phenomenal progress. I think you would agree in that we are looking at the model that Missouri had used and requesting an additional waiver. That's a lighter waiver than what's offered, but many folks on that waiting list, that's all they really need. This could take a lot of people off that waiting list. So we're encouraged by that. Moving on to 31.
31, we marked this one as in progress. This is for family treatment centers. This would be a SUD inpatient treatment facility that allows family members to be present with the patient while they're in treatment. And this is something that we continue to make progress on. There have been several women's facilities that allow children, and we have at least one facility that's taking men at this point. This is something that still requires additional funding and further expansion around the state in order for there to be, adequate facilities of this type to serve the population.
And for the listeners, could you tell us what SUD is?
Substance use disorder.
Any questions, committee? Moving to 32.
For 32, I marked this one as completed. I believe it was considered completed in 22. This was a request for the Bethel Committee to review extending Medicaid postpartum coverage period to 12 months. KDHE was able to get that put into their state plan amendment, so that's now a covered service or eligibility standard for Medicaid.
Number 33.
Number 33, marked as in progress. This is for the state hospital EHR. KDAS is currently under contract with a provider, and there's progress being made on implementation of that at all 4 state hospitals, but it's not fully implemented yet.
Any questions, committee? Number 34.
34 is 7.2, which is the data and survey informed opt-out. This is an ongoing issue that remains a challenge, and I'll talk about that a little bit later in another presentation, I believe. But there's communities that care survey, as well as some additional federal level surveys that we do that because of the opt-in language, participation in those surveys has dropped in some areas to the point where we're not able to publicly report out data, which then limits the usefulness of the survey, obviously. So it's a challenge. We've had a bill that has been introduced in committee the last 2 years that hasn't made progress out of committee yet.
Could you please explain what is meant by informed opt-out?
Yeah, so an informed opt-out basically means that the parents are told what the survey is for, and when the survey will be conducted, and they get the opportunity to review the survey questions if they desire to do that. And then they can make an informed decision about whether or not they want their child to participate in that survey or not. But everybody is automatically included, and you have to basically indicate that you want your child taken out of the survey so that they're not participating.
Any other questions, committee? Number 35.
Number 35 is in progress. This is 7.3, which is around information sharing. This is to utilize Medicaid funds to incentivize participation in health information exchanges, similar to KHIN or LACI. So we've explored this. We've submitted a budget enhancement last year that was not funded. At this time, we would continue to consider it an in-progress recommendation. But I'm not optimistic about its future.
No, we have RFPs on a new data system, correct? Could that not be, this be part of that RFP or no?
Well, so the RFP that's out now, and I believe they're in the process of making an award on that, is for what's referred to as a closed loop referral system. And what that does is it allows for providers to share information about the referrals that they make and then the outcomes of those referrals on the other end. So it shares information back and forth between the agency that made the referral and the agency that receives the referral, so that there's better patient care coordination. But it doesn't do exactly what this is intended to do, but it does do a part of it, if that makes sense. I don't think it's linked to the HIUs, though.
Thank you. Committee, we're ready for 36.
36, this is a needs assessment, 7.4, to conduct a statewide needs assessment to identify gaps in funding. This is something that has not been conducted to date, and I think it's largely on account of resources and time availability for staff.
Any questions, committee, on 36? Ready for 37.
37 is, again, around cross-agency data use. So this time, instead of providers, we're talking about state agencies. And this was intended to develop policies that improve our ability to access and review cross-agency data. So KDADS has been working to improve and finalize MOUs with multiple agencies. This year, we made progress on new agreements with KDHE, KDOC, and KDOR. And we'll continue to work on that to make sure that there's adequate data sharing agreements in place. One of the goals, I think, is we still need to work on one with ks.gov, but we're working on trying to get those in place.
Questions, committee? Number 38.
38, this is another one that we marked in progress. It's also one that was added new in 2021. And this is to work with the what we refer to as the SEOW, or the State Epidemiological Outcomes Work Group, which is part of the Governor's Behavioral Health Services Planning Council. I marked it in progress because so far no guidance has been provided to the legislature or KLRD as to what, we haven't received, I guess, let me back up a step, sorry. What we're trying to accomplish, right, is a list of metrics or other outcome measurements that the legislature would like to see presented to them by the SEOW, so that we can establish that. And I think there needs to be some additional conversation so that we can establish and agree upon what those metrics or outcomes measurements would be.
Any questions, committee? Senator McGinn.
Like, what kind of things are you looking for in that area?
Well, so the Epidemiological Outcomes Work Group, what they're able to do is look at, what evidence-based practices we've been implementing within our system, and then look at what our utilization data is, as well as what our survey data is, to kind of identify whether or not we're making progress on goals. And they could be things like, hospitalizations, readmissions, successful discharges. There's a number of things that we could potentially put in there, but I think it'd be helpful to get some feedback from this body about what sorts of outcomes there's interest in monitoring, so that we can work on getting those reports set up.
Thank you.
That's an excellent question. I believe we have Senator Baumgardner with the question. Could you tell us which item it's related to, Senator Baumgardner?
Yes, and thank you, Madam Chair. I tried to hit the button as quick as I could when we were on 37, and my question was simply, we know that there are RFPs out there with many of our different agencies about new IT services. So when we're looking at 37, is anyone overseeing to make sure that with the RFPs that there will be that interagency or from agency to agency ease of sharing information?
That's a difficult question for me to answer. I do know that like we work closely with our state IT office on a number of initiatives. So whenever we're at KDAD's working on putting forward new software, that gets reviewed at a higher level. I believe with the intent to make sure that it has the interoperability that's needed to allow for interagency sharing.
Thank you, Madam Chair.
So adding to that question then, I'll go back to the RFP. So will that do that? Will that allow interagency sharing of data and information?
Yes, so the RFP that came out of the Spark Committee, it was referred to DCF for fulfillment, like that product is something that would be a statewide, and each state agency would have user access to it.
Thank you. Let's move to 39.
Okay, so for 39, this is around correctional employees. It's recommendation 8.1. This is to expand training provided in state correctional facilities, local jails, and detention centers to better recognize substance use disorders and develop trauma-informed approaches to identify other mental health needs and then connect those needs with available services. This one was marked as completed. KDOC delivered a training to all staff in substance use and evidence-based practices. So that was done in 2021. We also have been working at KDADS with the CMHCs in order to deliver mental health first aid training to correctional staff. And also working with those jail liaisons that were talked about earlier to help connect to services for individuals that are coming in and out of the jails.
Committee questions on 39. Moving to 40.
So 40, this is 8.2, Criminal Justice Reform Commission recommendations. This is a large set of recommendations. I've marked it as in progress. We do have a multi-branch task force that's been convened so that each of the branches of government are represented on that task force. And I feel good about that being a good approach to meeting some of these goals from the recommendations list.
How often does that task force meet?
Right now, we're meeting quarterly in the large group, and then the subcommittees are meeting, I believe, on monthly or bi-monthly.
And are we any closer to developing a process for regular reporting on implementation, status, and outcomes?
I would say not yet on that one. I think we're looking at how we can better pull those resources together. I think the MOUs that we got signed this year will help with that. But it is something that continues to be a need.
Right, number 41.
All right. So 41, this is around law enforcement referrals. It's recommendation 8.3. This one was marked as completed, and it was to increase utilization and developments of evidence-based SUD referral, as well as treatment and recovery services for law enforcement contacts. So it was revised to include increased access to inpatient, residential, and outpatient services. So this is something that KDOC has worked in cooperation with a contractor to make sure that there's SUD assessment and referral systems in place for residents that are entering their system. And then those members are eligible for MAT treatment. And when they come back out of the system, they're connected to Heartland Radar, which then sort of monitors their progress and helps make sure that they integrate back into the community safely.
Committee questions? Number 42.
42, this is 8.4, which is defining crossover youth population. This one was also revised in 21 to add on, coordinate with the juvenile corrections advisory boards to ensure local implementation aligns with statewide policy team recommendations. So DCF has a Kansas crossover youth state policy team that has defined the population with a goal to provide those services to their families. And they also are working with any youth that's at risk or entering foster care on MST, which is a evidence-based model for family treatment for older youth, and expanding that availability around the state.
Committee questions on 42. Number 43.
So number 43, this was new in 2021. It's 8.5. It's a regional specialty courts or venue transfer. Again, this is something that multi-branch task force has been convened and is working on. We've got a subcommittee that's specifically dedicated to specialty court implementation, and there'll be some recommendations coming forward from that group on ways that the legislature might be able to help with that expansion.
Senator Baumgardner, you have a question?
Thank you, Madam Chair, and I apologize. It is back on 42, which, the status, it says it's completed, but when we look at the response from DCF, it states that they've defined the population. DCF has available to any youth at risk of entering foster care evidence-based mental health services. It says it has them that available, and yet that's not consistent with what we're hearing about kids even in foster care receiving mental health. So how is that available for every at risk of entering foster care? How is that even available to them? Who is doing the assessment, and how are they getting those services?
Yeah, so there's two levels of that. The first one is the DCF contractors. So for both the family preservation and for the foster care services, when they do an intake, they're going to do an assessment to help determine if there's a need for mental health services. And that's supposed to happen, almost immediately. Then our CVHC system and our CCMACs have in their agreement language from DCF that allows for definitions of the timetable and the level of care that's assigned to foster care children when they are brought to the CMHC. So the foster care worker or the foster family contacts the CMHC. They have an immediate triage that they do to help determine if the need is an emergency situation where they require care immediately, or if it's something that's urgent care. If it's urgent care, they have up to 24 hours to get that child in to see someone and do their intake assessment. And then they have 10 days to complete their full evaluation.
Okay.
Senator Baumgardner? Oh, go
Yes,
ahead.
thank you, Madam Chair. I don't think that we've seen any data on this. It's one thing to say it's available, but to say it's available to all of these youth at risk, or any youth at risk, I think that's a stretch, because we know we have pockets that aren't being served with mental health services. Thank you, Madam Chair.
I've heard the same, again, when I'm reading this, it says defining the crossover youth population, and then that was revised in 2041, which is coordinate with the juvenile corrections advisory boards to ensure local implementation aligns with statewide policy team recommendations. And I would agree that that portion is not complete.
Okay.
So Senator Baumgartner, are you making a motion that we change this to incomplete?
I am. Thank you, Madam Chair.
Okay, or in progress. And do I have a second? Representative Carpenter, committee, all in favor of making this in progress, say aye. Opposed? It is going to be back to in progress, and we are ready for number 44.
Okay. So number 44 is another recommendation around specialty courts. This is to fund positions in the judicial districts in order to allow them to hire specialty court coordinators. This was a new recommendation in 2021. And again, this is one of the things that subcommittee of the multi-branch task force has been working on. And I anticipate there'll be a recommendation around that for the legislature.
Recommendation will be this fall, as you mentioned.
Yeah.
Number 45.
Number 45, this is 8.7, which is to work on competency evaluation and restoration. This was to look into a pilot for the CMHCs to conduct mobile competency evaluation and restoration and then report to the 22 legislature. There was a passage of House Bill 2508, which both funded and sort of established language to allow for mobile competency and restoration within the state, working with the CMHC system to do that. So KDAS now has a contract in place that provides that service, and so we've marked that as completed.
Representative Carpenter.
Thank you, Madam Chair, and maybe it's in the description of the recommendation. So at our last CanCare meeting, we did find out from Scott that the Wheat State contract was approved. A couple of things here. Do we have a map of who is served? I know there's, Sedgwick County, the more populated counties already have these in place. But for me, for this to be completed, and it's a wording issue for me, it's when we don't have anybody waiting for competency and evaluations. And that couldn't be farther from the truth. In CanCare, we had 163 people out there. And then the issue is where to put them after they're evaluated, because we don't have any space at Larned for them. So I'm just saying, yeah, maybe this small wording, the way it is completed, but the issue is out there, ongoing. And so I just don't want to be lulled into some kind of a deal that we've all of a sudden, fixed our competency and evaluation program. So, but I would like to see maybe the rest of a map of who is covered under the CMHCs or does competency evaluations. I think we've never had that before. And of course, with Wheat State coming online, it would behoove us to understand where that is. So anyway, if we did anything, I would change the wording of that recommendation to reflect more of what I'm just talking about. It's still unacceptable to have 163 people waiting for those slots.
Yep. I'm sure the Sheriff's Association would agree with you, too.
So what I'm hearing you say, Representative Carpenter, is yes, they've completed look into a pilot, which is what they were requested to do, but there's more to be done on competency and evaluation and restoration. And so when we make our recommendations, we can refer to number 45. And I agree that I think it would be helpful to have a map of who all is affected or what areas would receive these services for the mobile competency. Number 46.
Okay, so number 46, this is around the regional model. And this recommendation was merged into 2.2, which we've already discussed. So I'll skip over that one if that's okay.
Yes, go on to 47. Oh, never mind, we're back to 46.
Thank you. I'm glad that came up because I
Yes.
was asleep when we
Oh.
did 2.2, and I woke up. And so in that 2.2, if that's the one that addresses SIAs,
Yeah.
is that correct?
Yes, it is.
So we see those beds, but how many of those beds are involuntary?
So on the adult side, for the SIAs, I believe we have maybe about 24 beds that are considered involuntary beds. That doesn't mean that an involuntary patient has to be admitted by that particular hospital, though. They get to make individual assessments of the patient that's referred to them at the time that that patient's referred. So each time it's an individual decision by the provider about whether to admit an involuntary patient. So it's a low number out of the overall number of SIA facilities.
Correct. And
Yep.
so that does, your number, your 20 doesn't include OSH, does it?
No.
Okay. But that was what lulled me, and I asked those questions before, was we see those beds, but yet we still have involuntary wait times because the people, the state alternative folks don't have to accept those involuntary, and they don't have the facilities. I'm not
Yeah.
being critical of them. If it's a violent patient or something like that, they just say, hey, we can't handle them. So don't be lulled into the fact that we had all these beds when a lot of our needs are in the involuntary arena.
Capacity, yeah.
Okay.
And I think too, that the project in Wichita is going to include a number of involuntary beds as well. So we'll hope to see some pressure valve release on that wait list there too.
Number 47.
Okay, so 47 is marked as in progress. This is around long-term care access and reform. It's recommendation 9.2. So we're continuing to work on our long-term plan for this reform. We've established an NFMH pre-litigation settlement agreement with DRC and some other stakeholders in order to try and work on community integration to make sure that there's both active treatment and rehabilitation services that's happening within the NFMHs, but also that we're expanding our community-based services to support those individuals and moving back into the community.
Any questions on 47? Moving to 48.
All right, so 48 is 9.3. This one is around integration care. And this was revised in 2021 to just add an example. But this is to look at how we can continue to try to, that's kind of the topic of discussion yesterday, like how we can blend primary care and behavioral health care in a way that integrates services and moves patient care forward in a positive manner without hindering our workforce situation or causing problems within our provider networks. So we marked this one as in progress because there's a lot of work that we're continuing to do on this. And we really are, I think, making good progress. We recently received a federal grant that will be a $5 million or 5-year $1 million grant, $2 million grant. $2 million for 5 years, so $10 million total. And that grant is for us to work with the FQHCs and the federal lookalikes in order to try to expand behavioral health care in rural areas, especially around Kansas. And so we're looking forward to implementing that. And that project will start, I believe, in September or October as we get that program off the ground. But that's just one example of the type of work we're doing on that issue.
Questions on 48? Moving to 49.
So 49, this is 9.4, which is evidence-based practices. And this really just talks about continuing to look for ways to provide housing and supported employment, EBPs. So we marked this one as completed. Both KDADS and KDHE, as well as DCF, have been involved in these through Voc Rehab and Medicare or Medicaid. So we're making good progress on this, and we've built it into our systems for reimbursement and those kinds of things. So we are right now. I think the main advocate position is we just need to increase the reimbursement rates.
Committee questions on 46? I'm sorry, 49. Moving to 50.
So for 50, this is around family psychotherapy. This was really just to add a specific code to the Medicaid system, and we've done that.
51.
51, this is around quality assurance. And these were specific to high-quality telehealth services. I left this one as in progress because I believe that we still have a lot of work to do on developing our state-level standards and making some determinations about whether to allow telehealth from outside the state, those kinds of decisions that need to be made.
52.
52, we marked this one as completed. This is 10.2, the reimbursement codes. And this was really to allow for expansion under public health emergency. And so we were able to do that, and we've been able to sustain those expansions after the public health emergency ended.
Questions on 52? Moving to 53.
53 is similar. This is another telehealth for crisis services. And again, these services were expanded for telehealth, and after the telehealth or after the public health emergency, we've continued that expansion.
Number 54.
So number 54, this is another telehealth related recommendation. This one I've left as in progress. And it was revised in 2021. But it wants to make sure that telehealth is available in the most appropriate locations. So examining issues related to the state line issue, as well as how to look at private health insurance coverage and things like that.
55.
Number 55, this is around child welfare system and telehealth. I've left this one as in progress as well. This was to better use telehealth to maintain service and provider continuity as children move around the state. So we're continuing to look at that. And there's a number of sort of technology questions that need to be answered about how we might be able to make sure that there's something that's traveling with the kids that allows them to maintain that telehealth connection.
You say something that's traveling with the kid.
Yeah, like a phone or a tablet or some kind of device that allows for the telehealth to occur.
I see. Number 56.
56, this is telemedicine committee. And this was just a recommendation to the LCC to establish a special committee on telemedicine modernization. And to the best of my knowledge, that hasn't occurred.
And who would coordinate that? In other words, I'm wondering why was this dropped and why has this not occurred since 2021?
I'm not sure I know the answer to that question, Senator.
All right, we'll check. Thank you very much. To those on WebEx and those in the room, I know this was riveting information. And also, everybody knows that I am a stickler on staying on time. We will make up the difference in the air. Some of you are looking at me like, what are you talking about? If you've ever traveled, you've heard the pilots say we're running 10 minutes behind, we'll make up the difference in the air. We do have a 10:30 break that was put in, and we will not be using that 10:30 break. That was put in if needed, but we need to continue to try to get back on track. And Representative Landor has a comment.
Yeah, I think, Madam Chair, that any gathering of information or reports that we've requested today, that those should be provided to the Bethel Oversight Committee, because if it doesn't go to a standing committee, it just gets lost in the process. That would be my recommendation.
I totally agree.
And I don't know, Andy, are you kind of in charge of the checklist that was attached to the mental health modernization report? Or someone in your agency, or?
I would say that within my agency, I'm responsible for it, yes. But I don't know that I can assume responsibility for the other state agencies.
Okay. Would that be possible later today? And if not, definitely for Bethel, to see what recommendations were made, but they weren't able to be fulfilled because of funding. At that time, there just was not funding for all of that. Is that something that you could take and do for us?
Yeah, I believe we
For
can work
Bethel?
on that. Yeah.
All right. And then one of the things that I noticed, Madam Chair, going through this report is we'll see a section here that deals with foster care and a section over here that'll deal with foster, and there's no accumulation. So some way, somehow, however the agencies or maybe even staff can be very helpful in this, is how can we put these in, either, I don't care if it's squares or circles, so that they tie together. So we're looking at the programs as a whole, because we may be duplicating and fragmenting, and that doesn't help us anywhere. And some of those, if you combined them, you could actually get them completed. So that's a deal for staff. And again, I think that would go to the Bethel. And then also including, the agency and the funding source for those. Thank you, Madam Chair.
Thank you, Representative Landwehr. Now we will move to 988 and the general suicide prevention presentations. And oh, hey, Andy, you're already up at the microphone.
And I'll try to go through this quickly. So we've had the opportunity now to work on 988 for about a year, and we've also been working on suicide prevention in Kansas for quite a long time. But under the current administration, we've really tried to figure out ways that we can invest in state infrastructure. So on this first slide, on page 2, we're looking at the 988 prevention hotline. And this is just some additional information, but we're in our second year of implementation on this. The coordinating council was established and has been meeting regularly. We're working to support the 988 effort by managing both state and federal funds and looking for ways that we can continue to leverage federal dollars as well as the $10 million that the state awarded. So on slide 3 for 988 in Kansas, this is just background on the legislation that was passed that allows for the funding for 988 and establishes KDADS as the agency that's receiving those funds and helping implement that program. And then on slide 4, this is the 988 Suicide Prevention Hotline information about the network. We currently have 4 988 contact centers that cover the state. Douglas County is covered by Kansas Suicide Prevention Headquarters. Johnson County is covered by Johnson County Mental Health Center. Sedgwick County is covered by ComCare. And then Kansas Suicide Prevention Headquarters is the primary answering contact center for all the rest of the Kansas counties. And then we have in Shawnee County Health Information Solutions. which is our statewide backup. So if there's any calls that Kansas Suicide Prevention Headquarters isn't able to capture, they roll over here in Topeka. And then we're currently working on developing a 5th contact center in Wyandotte. Our 988 goals are listed on number 5. Primarily on this one, I just want to highlight that we're working on expanding our chat and text response operations, and I think you'll see recommendations coming from the council about needs for that expansion. And then we'll also probably provide some recommendations about the overall funding mechanism. On page 6, you can see this is a state map or a national map of where each of the states is at in terms of their in-state answer rates. You can see that Kansas is actually doing very well. We're in one of the 14 states that is actually answering above 90% of the calls in state. On slide 7, this is the Kansas suicide prevention efforts. This is where we'll get into a little bit of the state infrastructure. So we've been working over the last 5 years with the National Suicide Prevention Resource Center to really try to build missing pieces of state infrastructure around suicide prevention. We've worked with the legislature to increase state funding for suicide prevention efforts, including funding for the Kansas Suicide Prevention Headquarters Resource Center and funding for the statewide Suicide Prevention Coalition. We were able to start a postvention program that helps survivors of suicide. We've been able to fund a man therapy program, which targets males that are at a high risk for suicide here in the state of Kansas. We also have been able to secure a 5-year Garrett Lee Smith grant that will help fund local suicide prevention programs in Wyandotte and Southeast Kansas. And we've now dedicated a full FTE for a state suicide prevention coordinator that was part of the 988 bill. And that's state funded as well. And we have a federally funded FTE for the GLS grant coordinator and our 988 coordinator position. On slide 8, this is about our state plan. So our Governor's Behavioral Health Services Planning Council Prevention Subcommittee develops the state plan. It's a 5-year plan. It's reviewed annually and updated as needed. And we work with a lot of other state agencies that you're going to hear from after I'm done talking. And then we also use that plan to outline the responsibilities that are necessary for us to make progress on suicide prevention rates here in Kansas. On slide 9, this is the Kansas suicide prevention efforts for the state plan. These are the 4 strategic directions and the related goals and objectives. The full plan can be found at the link that's listed, but it's like a 56-page document. So I didn't provide that directly, but you're welcome to look at it on your own. But we focus really on healthy and empowered individuals, families, and communities, developing clinical and community preventative services, looking at how we're improving access to treatment and support services, and then really starting to look at what our surveillance, research, and evaluation of those programs and rates are around the state. The next slide just kind of shows how those fit together. And the idea really is to prepare communities to be suicide safe or suicide safer. We were trying really to make sure that we're able as a state agency to provide resources at the local level to help folks build those plans and put them in place. Suicide prevention plan on page 11. This just goes into the specific goals that we're looking at within the plan. And you can see that a number of those things are things that we have talked about, both with the 988 Coordinating Council and also with our Mental Health Task Force and our other Governor's Behavioral Health Services Planning Council recommendations. So I'm not going to go over those in detail, but they're there for you to review if you'd rather look at a shorthand version of this plan. And then, the last thing I'll point out is like we are trying to do an annual review and report process to make sure that information about that is getting out to the public. So are there any questions?
Questions, committee? You're done.
All right, thank you very
Toast.
much.
You're out of here. Thank you very much, Andy, for the information you've provided us today. Next, we have Laura Moore, the Youth Suicide Prevention Coordinator, Office of Attorney General.
I'm Dana Zolk with KDHE.
Oh, okay. So you're in place of the AG's office?
No, Laura is also here, but I'm scheduled after Andy, I see.
Oh, okay. Oh, never mind. I didn't look under Andy's section, so I apologize. Proceed.
No worries. Good morning, members of the committee. I appreciate being able to be here. I'm Dana Zolk. I'm the Section Director for Injury and Violence Prevention Programs in the Bureau of Health Promotion at the Kansas Department of Health and Environment, and I'm sharing with you a presentation that our advanced epidemiologist, Lauren Gracie, put together. She oversees the implementation of zero suicide in health systems. KDHE, I believe you have this presentation, but I'll just say KDHE was awarded this funding from SAMHSA in August 2020. It is a 5-year funding opportunity, $700,000 per year. And it focuses on adults 25 years of age and older. The grant centers around the 7 elements of the zero suicide framework. If you'll move to slide 4, zero suicide is a way to improve suicide care within health systems. The mission of zero suicide is a quality improvement model that transforms system-wide suicide prevention and care to save lives. We want it just to have, to be as normal and have the policies, practices, and protocols in place as if someone were presenting with a heart attack. The hospital knows exactly what to do. We want that for someone who's presenting with suicidal ideation as well. On slide 5, there are the 7 elements of zero suicide. I will mention that zero suicide in Kansas is led by an advisory council who helps us with consultation and technical assistance for all of these elements. The first element is lead. It's really important to have multi-level champions for zero suicide and to have multiple departments involved in zero suicide for any agency that's implementing. Train is the second element. Having a competent workforce on all levels is extremely important to suicide prevention. Identify as the third element, which involves universal screening for suicide prevention, or suicidal ideation, I should say, and that includes the Columbia Suicide Severity Rating Scale as the gold standard. The next item is engage, so allowing those with lived experience and those, yes, ma'am.
I might have you pause for just a moment. For those of us who are trying to follow this, Diane's testimony is under Laura, is it Gracie?
Correct.
Yes. So if you looking for that testimony, that's the name you're looking for on the website. Thank you.
Thank you. The fourth element of zero suicide is engage. We want those with suicidal ideation to be involved in their care plan. Treat is the fifth element, so having evidence-based prevention efforts in place and treatment opportunities for those with suicidal ideation is that item. Transition is the next element, which involves warm handoffs. So discharge from an emergency department or inpatient behavioral health care is often one of the biggest gaps that's seen, and so providing that transition, or like I said, warm handoff to behavioral health care providers and caring contacts is a critical piece of closing this gap. And then improve is the last element, and the agencies that we fund are responsible for tracking their patient outcomes, identifying gaps in their care to create formalized processes, protocols, and policies specific to suicide care. I do know that your agenda is under a bit of a time crunch. The next section of the presentation is statistics. Is it your preference for me to go over these or for you to review them at your leisure?
We will review them. Thank you for presenting them or sending them to us.
If you'll skip to slide 18, please. We will review just briefly what we are doing here in Kansas for the implementation of zero suicide. On slide 19, you'll see our list of partners who are involved in our advisory council. On slide 20, these are the elements and how we are implementing them. We have three main goals with our contracting. One is contracting with Kansas Suicide Prevention HQ to provide trainings, make them free and readily available to those who are providing suicide care. We have a contract with Kansas Healthcare Collaborative, which is a pilot program to expand zero suicide in primary care clinics. And then the big one is the third one, and that is having entities implement all 7 elements of zero suicide. And we currently, we're in year 3 for just a few more days. We have 6 entities who are implementing the framework of zero suicide, and beginning August 31st, we anticipate having 8 entities in our state implementing. We also have several who are unfunded implementing zero suicide. On slide 21, it discusses how we're raising awareness of zero suicide. We've developed many written materials and infographics. We're presenting and exhibiting at conferences at the local, state, and national levels. We're hosting zero suicide workshops and academies, and those are followed up by 9-month-long communities of practice. We've leveraged our relationships with other state agencies, coalitions, health and behavioral health care organizations to share the model and their successes. We have a web page that went live in 2021, and we published a suicide data dashboard in 2022. Of course, we're sharing as much data as possible with all of our partners across the state, and that includes when there is an identified spike alert, and that information will go out to our community mental health centers and local health departments. For instance, for July 2023, we saw a spike in those identifying as female of childbearing ages having the emergency department visits were drastically higher when comparing to months previous. On slide 2022, it addresses LEAD. All of our funded sites have implementation teams that meet regularly. We have persons with lived experiences on those teams, and all of the agencies are expressing leadership support. On slide 2022, there are our great accomplishments with TRAIN, again, with ks.gov as our lead agency. We've had more than 3,700 attendees for suicide prevention trainings, ranging from gatekeeper to CAMS to our full academy to creating or counseling on access to lethal means. On slide 24, it addresses identify and engage. Over 35,000 individuals have been screened for suicide ideation, and we continue that screening beyond these numbers here. The 46 individuals enrolled means that they've completed NOMS, which is a national outcome measures, and we've had a lot of lethal means access items distributed, over 2,000 gun locks, 900 medication lock boxes, and nearly 1,700 drug deactivation bags. In addition, our organizations are supporting local efforts for drug take-back days. On slide 25, you'll see the elements of treat, transition, and improve. In years 2 and 3 of our grant, over 2,000 people were referred for treatment of suicidality, and all agencies reported using evidence-based treatments. Currently, most agencies have policies in place to refer out to their local community mental health center for suicide assessments and treatments, and the transition element is vital, again, with those warm handoffs and caring contacts. Over the last year, our funded agencies have grown their improve element drastically. This time last year, only one agency had a policy in place to assess their organization's fidelity, and currently there are 4 agencies with this policy. We do receive quarterly reports from them. Again, not only those who are funded through Zero Suicide, but those who opt to participate and receive support from our organization. 15 total agencies supported or submitted data most recently, with nearly half of those not being funded. And I will stand for questions at this time.
Committee, are there questions for this conferee? Senator McGinn.
I'm new at having to find my slides on the computer. I found one set of slides, but not these.
Okay.
There's like 9, and they look totally different than,
Okay, I can help you with that.
so you have what you saw. Okay. Yeah, that's what I clicked on. Mine's different.
I don't know.
Mine too.
And you went under committee documents? It's on page 2.
Right.
Yeah.
Yeah, go to page, no, next page. That's. it's
Oh,
not
her
on
next
Laura.
page.
Yeah, and then Laura and up there.
Okay.
Now we found it.
Where is
There's
she?
Laura and then,
Lauren. Got it.
yeah,
Thank
Laura
you.
and Lauren. I was on Laura too. Okay.
I apologize for any
That's all right.
confusion.
I had it memorized, but I just wanted to share
Okay.
with others.
Yeah. All right, thank you. It's always a bit confusing if the name of the conferee is different than the name that's on the presentation. Thank you so much for your thorough presentation today. I have just a couple of questions regarding this, and that is when I went to visit the 988 Center, it was quite impressive with everything they're working on and the people that they're bringing in Douglas County to train them, et cetera, social workers and so forth. But one question that I've asked that they're going to get back to me is how many unique calls do they receive on a monthly basis? Again, I see my job as a senator is to overwatch the people's money. They send their hard-earned money away from their own families to us, and are these funds being used appropriately and most efficiently? And so this program has been in effect now for the past year, and I'd like to have more data on, yes, we're preventing suicides. Well, that's terrific, but how is the 988 Center doing that? And what is some of the data that we could have? Look, we all know that there are some people that try to make a phone call because it doesn't cost anything. I can make a phone call. This is a warm person to talk to. And so then they said, yes, we do have those people who call in and they are repeated. They have a term, but people who call in repeatedly. But we wouldn't want that number included in this is the number of unique callers that we had. But then again, they took somebody's time, when they called. And sometimes that's a lifeline. They really don't have anybody else. They're very lonely. They're having an episode again, whatever. So the more data that we can get, and again, we want this obviously because of PHI, that this be, and HIPAA, generic information. The average age of the caller is this. The average reason why they call us. So here are some reasons why we get calls. We don't have that information. That information would be very helpful to this committee. Committee, are there other questions?
And I might just say that that is not information that I would have, but
Yes.
some of others in the room would have that
Yes.
information. Specific to Zero Suicide, we do have a data dashboard that has very excellent information on it, and I would encourage you to visit that.
And that is regarding,
specific to zero suicide and those who are implementing the framework. So it's going to have information about suicide, emergency department visits, hospital discharge visits, deaths. It's going to have information about all of the trainings that have been done and those.
Some of the data that you gave us today in your report. Great. And again, we just don't have a place on here for the 988 phone centers. And so that's why I'm bringing it up, not necessarily to you, just generically, and I see Andy nodding. Thank you so much for being here with us, and I think we do have a call from Senator Holscher.
Actually, I got it answered, so thank you very much.
Very good.
Very good, thank you.
Thank you for being with us. Committee, we're going to move to the youth suicide prevention with Laura Moore. And this would be the one that both of my colleagues pulled up initially.
Probably the 9 slides, yeah.
Okay.
Okay, we good? Okay, good morning. Thank you, Madam Chair and committee, for your time and for inviting me to speak today about youth suicide prevention. In late spring of 2018, the Tower Mental Health Foundation and Attorney General Schmidt formed a task force to survey efforts underway in Kansas that were focused on reducing youth suicide. In response to the recommendations of the task force, Kansas legislators passed House Bill 2290 in May 2019. This bill included the description of a youth suicide prevention coordinator position, as well as goals for the position. I'm here today as the Youth Suicide Prevention Coordinator in the Youth Service Division at the Attorney General's Office. Slide. Okay, so a little bit of data. First, we're looking at what myself and my agency are doing to address youth mental health and suicide in Kansas. Here, you can see the most recent Kansas Child Death Review Board report that comes out of the Attorney General's Youth Service Division. It shows that in 2020, 26 children in Kansas between the ages of 10 and 17 died by suicide. 22 were male and 4 were female. Of the young people that died by suicide in 2020, 66% were currently receiving or previously had received mental health services. 54% communicated their suicidal thoughts, actions, or intent. 31% were known to have attempted suicide previously. Slide. I often use and share the State Child Death Review Board report and the data that's included that we just looked at. But I also use self-report data from the Kansas Communities That Care survey, as well as data from KDHE's Violent Death Reporting System. Here, we are looking at KCTC data that compares the 22 Kansas data from 10th and 12th graders with the most recent national data from 10th and 12th graders that were reported in 2019 in the Kansas risk behavior in the youth risk behavioral surveillance system. This graph shows that the percentage of Kansas youth that reported experiencing depression and suicidal thoughts are above national averages. Slide. Here we're looking at KDHE Violent Death Reporting System data that came out in between 2016 and 2020. More than 3 in 4 violent deaths among 10 and 17-year-olds in Kansas were suicide. 1 in 4 of those aged 10 to 17 who died by suicide were in 8th grade or less. 3 out of every 10 to 17-year-olds experienced a crisis in the 2 weeks before they completed suicide. These data points and many others that we have show the mental health crisis our young people are experiencing. Slide. In September 2022, Attorney General Derek Schmidt released the youth suicide prevention app, Kansas, A Friend Asks. This was created in partnership with the Jason Foundation, a national youth suicide prevention organization out of Tennessee. Kansas, A Friend Asks, connects youth to tools and resources they can use to help a friend or themselves who may be struggling with a mental health crisis or thoughts of suicide. We know that youth talk to their friends. We believe if we can support their friends and ensure youth have the necessary tools to help a friend through a mental health crisis, suicide completion numbers may go down. Slide. The app describes what warning signs of suicide might look like, gives suggestions for how to help a friend, things like what they can say or what they shouldn't say when a friend has expressed thoughts of suicide. It directs users to the SAMHSA website, helping them find the closest substance use or mental health treatment center, and it also enables users to connect to 988, the National Suicide Crisis and Lifeline that we just heard a little bit about. After a recent update, users can now toggle between Spanish and English in the app, and we're always looking for ways to update it and keep it relevant and accessible to Kansas youth. So far, in the United States, there have been a total of 6,462 downloads of the app. Since the release of the app, the Get Help Now page that connects users to 988 has been visited 149 times. In the Youth Service Division, I work with the DARE coordinator and network with school resource officers and DARE instructors that work in schools and with youth. This enables me to get youth suicide prevention resources, like information about the app, directly to these kiddos. I believe that the biggest mission of my position is to support and partner with other state agencies, mental health organizations, and establishments that support youth. Together, we collaborate as we review data, assess need, and support the implementation of successful mental health strategies at a state level. Together, our goals are to ensure access to mental health care, lessen the crisis youth are experiencing, and prevent suicide. Thank you for your time, and I would love to answer any questions that you have today.
Laura, thank you so much for being in your new position. And committee, do we have questions for Laura? Yes, Senator McGinn.
Thank you, Madam Chair. I was just curious if you've done any data on what is it that's causing the depression and the crisis and all those kind of things? Because I have young kids that work for me, and I can't believe the stuff that goes on this little thing.
Mm-hmm.
And I mean, they're like, you know, they're tracking each other, all kinds of strange stuff.
Uh-huh.
And so I just wonder if you've been doing any studies about what's on phones and how much kids are using that.
There are a lot of places out around the world that are doing research trying to name the things that are causing depression, suicide ideation, things like that. And together, I think it's all of the things. It just depends on the situation, the kid. There's not one thing.
No.
But there is research going on everywhere. If we can find the cause, we could find the cure.
Okay. Thank you, Madam Chair.
We, many of us on the committee, received a heart-wrenching letter last evening from a mom whose child committed suicide. And I just wrote back to her, I mean, it's hard for me to even look at this or read this without tearing up. How very sad. But her daughter went on something called sanctionsuicide.net. Could you talk to us about that? Are you familiar with those websites that are actually encouraging kids to commit suicide, and they could order poisons, et cetera, and say this is a way to do it, and you know, egging them on, and that's not the only one. But what can you tell us about that?
I've heard of those sites. I think we all have heard of those, and it's just something that we're continuing to look out for and educating the public, youth specifically. For myself, I want to work with the kids, work with their mental health status, and let them know, prevent them from ever having to go or wanting to go to a site like that. But yeah, that is something that we are aware of, and as a nation, I think we're battling that.
Representative Landwehr.
And actually, Madam Chair, it was something I was going to bring up, because actually myself and a colleague in the House are working with the KBI director on this, because, and I don't know if this happens to be the same individual, but authorities told them that there wasn't anything that could be done, and our KBI director disagrees with that. So that is one thing that we have to watch. We also know that the thing is on mental health is that they have identified today that screen time, whether it be TVs, computer games, the phones, is impacting the mental status, and it's changing things within the brain itself. In your numbers here, do you have a breakout of rural versus urban
Which numbers specifically are you
on the
asking about?
suicides?
I don't have it with me specifically right now, but in the most recent Child Death Review Board report, it lists some demographic information, yeah.
Okay. That might be something we want to get, because I think those numbers would be really interesting to folks, because you'd suspect it to be one place and it's not.
Right, it's not, usually.
Senator Holscher, I believe, has a question on WebEx.
Yes, thank you so much. Yeah, I was just to kind of piggyback on what Representative Landwehr was talking about. I am curious also about the differentiation between rural and urban, because my understanding is that we are making progress as far as removing stigma of addressing mental health, but not so much in the rural areas. So like I said, I would be interested in kind of seeing some of that information to see how that breaks down. And then also to echo what Senator McGinn was saying in regard to the social media. I'm very fortunate. I have teenagers who talk to me and show me the things on their phones, and I spend a decent amount of time subbing in public schools. The social media and the bullying, if we are concerned about bullying, there's so much of it that occurs through the social media and the apps that are there that I would just encourage your office to do anything they can to help get their arms around that situation.
Representative Blacks.
Thank you, Madam Chair, and thank you for your report. Do we have, I find it a little bit concerning that 60% of youth suicides from 10 to 17 have a mental health service contact. Do we know, is that one contact? Do you have any idea is it 4 or 5? I mean, here we're putting a lot of money to something that is, I thought that would have been reversed.
Well, those contacts are like previous contact that was experienced at any point prior to the completed suicide. Is it one contact or two? I don't know that information specifically. I'm not sure if.
By definition of contact, is that with a licensed or a certified mental health provider? Is that correct?
Yes.
Wow. Thank you.
Representative Ballard.
Thank you, Madam Chair. Actually, I think it's even worse than we think it is in many ways. I participated at NCSL in a session last week, and I thought it was very interesting, something I knew, but you have to listen to somebody really tell it to you from a young person's point of view. You can never get away from it. It used to be, if it happened at school, you didn't have to deal with it again until Monday if you left on a Friday. Now you can't get away from it because it follows you on the internet. It follows you in social media. It follows you in invitations that you did not receive. It comes in all forms, so you can never get away from it. And her comment was, after a while, you begin to believe everything you see and you hear. And she says, no one could help me because you don't know what I'm going through. But she says it's a mental thing. My folks wouldn't understand because my sister didn't have the problem, so it wasn't like in the house. But she says it's everywhere. And her comment was, people worry about how much money we're spending on it. Her comment was, you don't have enough money to eliminate this because they're more powerful than you are, because it comes from all angles and all sides. I mean, before she finished, I think all of us were in just tears, because then you realize, and I thought to myself, would I want to be raising my son, my husband and I now? No, because there's too many competing things out there. And we worry about money. I worry about lives. But it was a real eye-opener about maybe where we should be looking, but how do we control social media 24/7? Thank you, Madam Chair.
Committee, other questions or comments? I just have one, Laura, and that is on your last slide. It has the 800 number for National Suicide Prevention, and that just needs to be updated to the 988.
I apologize.
No, that's,
Just so you know, the 800 number still does work, but it rolls to 988. But 988 is way smaller and saves space on slides.
exactly. And there is I don't have it with me, but when I visited the 988 Center, they have a really nice flyer that has when to call 911 on one side, when to call 988 on the other, which I think would be great to add to the site.
That's great. I will look into that. Thank you.
Great. You're welcome. Committee, Laura, thank you so much for being with us. And we are going to move to suicide in the Sunflower State. Wyatt Beckman, as Senior Analyst with Kansas Health Institute. Thank you for being with us. And if anybody's counting, we're back on time.
Thank you, Madam Chair, and members of the committee, and I'll be sure to keep us on time. I know we have lunch after this. Thank you for the opportunity to share some information with you. My name is Wyatt Beckman. I'm a senior analyst at the Kansas Health Institute. My contact information is in the slides there, and I'd be happy to follow up with anyone that has any questions. The Kansas Health Institute, on the next slide, we are a nonprofit, nonpartisan educational organization based here in Topeka. We're just across the street. I think my slides should be under my name if you're looking for them, and I think they're on the last page. And we were established back in 1995 with a multi-year grant from the Kansas Health Foundation, and we're committed to supporting and convening meaningful conversations such as the one we're having today around tough topics related to health. On the next slide, you'll see our vision and mission, vision of healthier Kansans through effective policy, and there's our mission, nonpartisan research, education, and engagement. The final slide on some backgrounds here, slide 5, you'll see our services. We do a variety of things at the Kansas Health Institute. If folks would like to learn more about us, that is a place you can do that. On slide 6, I want to pause and recognize that we have a whole team, a great team of folks at the Kansas Health Institute that have been doing work related to understanding and suicide and suicide rates over many years, and you'll see some of our recent work on slide 6. You also see on the bottom we have an upcoming convening that is a hybrid convening that's free to attend, and that link there will take you to find more information about that for anyone that is interested in attending that event. That is focused on the 988 Suicide and Crisis Lifeline and what we've learned in year 1. So if we move to the next slide, our agenda for today, I'm on slide 7 now. We've heard today we've had the opportunity to see, and you'll have opportunity to read more, some data from Kansas, from previous presentations. I wanted to first start by backing up and looking at a national perspective and the trend in suicide rates over the last couple of decades. Then I want to talk about some disparities in suicide what populations do we see higher rates? Where have we seen greater increases? And then we'll talk some about some most recent data, some provisional data from 2022. Then the second half, we will move into a couple products that we have done, recent projects that we have done that focus on youth suicide rates and urban rural suicide rates, which I know was mentioned earlier. So that'll be the second half of our time. So we'll start with the national perspective. So now I'm on slide 9. And here's the view of the national trend in suicide rates from 2000 to 2021. This comes from the CDC. You can see that overall the trend is increasing, and we've seen a 37% increase from 2000 to 2018. 2018 was the peak nationwide for suicide rates. Back in 2000, the rate was 10.4 deaths per 100,000 population. Most of the rates are going to be per 100,000 population. That's a way to standardize so you can compare as population totals change, so we can more easily compare that over time. So in 2000, the rate was 10.4 deaths per 100,000. That increased to a peak of 14.2 in 2018. And then you do see there was a decrease from 2018 to 2020. However, that decrease was almost completely erased in the last year on this graph. From 2020 to 2021, we saw an increase back up to 14.1, so almost back to the peak we saw in 2018. If we move to the next slide, this is focused just on 2021. 2021 is the most recent fully finalized data we have nationwide, and this is coming from the CDC. In 2021, we saw 48,183 people die by suicide in the US. This was one death every 11 minutes. And then on the right side of that graph, you can see number of millions of people that seriously thought about suicide, that made a plan, and 1.7 million adults attempted suicide. On the next slide, we're staying in 2021, and this is looking at means. And we know most recent data show that more than 50% of suicides, the means are discharge of firearms, and it's increased now to 55% of suicides nationwide. Firearms are the means, and you can see the other means there, suffocation, poisoning, and then other. I do want to point out that on all these slides, if you'd like more details or to see the source is linked at the bottom right of the slide, so you can get back to the source information. On the next slide, we look at means again, and in this view, this comes from KFF, or the Kaiser Family Foundation, and it's looking at number of deaths. So this isn't a rate, this is number of deaths due to suicide by firearm and then other means. So we've combined all the non-firearm means into one category. I want to focus on the right side of the graph, the most recent couple years. We can see that until around 2020, it was around 50% of other means and suicide by firearm. But recently, that's changed. There was an 8% increase from 2020 to 2021 in suicide by firearm. Then there was an additional 3% increase from 2021 to 2022. So this is relying on some 2022 provisional data that the CDC is finalizing and doing some quality assurance on. And as I mentioned before, now suicide by firearms make up 55% of all suicide deaths in the US. A related point, over 50% of all deaths that involve a firearm are suicides. as well. If we move to the next slide, I now want to point out some and talk about different populations and some disparities we see in suicide rates and suicide increases. So I know there are a lot of numbers here and a lot of charts, so we're going to take our time and walk through these. So this is another chart that comes from KFF, and there's three sets of bar charts here. On the left side is 2011 suicide death rate, and this is again per 100,000 population. That middle bar chart in the blue is 2021 suicide death rate, and then in the orange on the right is a percentage change from 2011 to 2021. So we're gonna start looking at the left side in that darker blue. So you can see back in 2011, the highest rates of suicide by race and ethnicity were among American Indian, Alaska Native, and among white individuals. The Black, Hispanic, Asian Pacific Islander were all similar and lower than white and American Indian, Alaska Native. If we move to 2021, that middle set, we see that the same general population still have the highest suicide rates. The highest is among American Indian, Alaska Native at 28.1 deaths per 100,000, followed by white individuals. In 2021, American Indian, Alaska Native people had a suicide rate that was 1.5 times higher than white folks, and that was the second highest group. Rates of suicide for Black, Hispanic, Asian, or Pacific Islander individuals is about half the rate of white individuals and even less compared to American Indian, Alaska Native. When we look at the final set of bar charts here, it's focused on percentage change. And we can see that American Indian, Alaska Native had the highest rate in 2011. They continue to have the highest rate in 2021, and they increased the most of any population group, increasing over 70%. The group that had the population that had the second highest increase were Black individuals, and they increased over 58%. And then we see Hispanic populations increasing 38% as well. So even though the Black and Hispanic populations have a lower suicide rate overall, we have seen higher rates of increase among those populations. The other overall thing you'll notice is that we've seen increases across all the populations. If we move now to the next slide, slide 14. So this is a similar chart. We have 2011 on the left, 2021 rates in the middle, and percentage change on the right. But now we're looking at age groups. You'll see that on the left side and in the middle, our adult age groups, while there are some small differences, are all fairly similar rates. They're all in the upper teens. 18 to 25-year-olds in 2021 were 18.1 deaths per 100,000. 65 plus was 17.3. They're fairly similar, and our 12 to 17-year-olds had a lower rate in 2011 and in 2021. However, you'll notice that on the far right, the increase was greatest among those young individuals. And I was preceded by a presentation on youth suicide prevention, and this is in line with that work. This is, again, national data that we've seen a 47% increase in suicide rate among 12 to 17-year-olds nationwide from 2011 to 2021. So in that 10-year period, over 47% increase. That was followed by the 18 to 25-year-old age group, which had a over 39% increase. The only population here in this specific 10-year period that had a decrease was 45 to 64-year-old, but you'll notice it's a small decrease. And the overall trend that we've seen, and you will continue to see, is unfortunately still increases across the board. Our last chart that looks similar to this one is on page 15. And we're now looking at two different groups, or two different categories. We have sex on the top and rurality on the bottom. We know, and you have heard in other data and some of the data from Dana and Laura that you'll have the opportunity to look at in Kansas is in line with this, that females are more likely to report mental illness and have higher rates of suicide attempts, but the rate of suicide death is higher for males. And that was true in 2011 and remained true in 2021. So rates of male suicide nationwide increased by 14%. So they were higher and they increased more. And among females, we saw over 9% increase. When we look at rurality, this is a simple urban, rural, metro, non-metro split. We'll talk later, look at some Kansas-specific data where we look at different population densities. But nationwide, we see that rates of suicide are higher in non-metro areas. They were higher in 2011, they were higher in 2021, and they've increased more rapidly. We'll now move to slide 16, and this is where we have the chance to look at some provisional data. So this is the most recent data we have nationwide, and we're focusing specifically on changes from 2021 to 2022. This information comes from the CDC, and the link is there if you would like to look into it more. Overall, we saw a 2.6% increase from 2021 to 2022. In this single year, which again, we know that rates fluctuate from year to year, but in this single year, we did see decreases among American Indian Alaska Native individuals and among youth in just this last single year. The numbers you see are not rates. These are number of total deaths. So earlier we were looking at rates. This is number of deaths, and you can see the different categories there. On the far right side, we'll see percentage change, and the age groups here on the bottom will look different a little compared to some age groups, but we did see in this last year a small decrease for the 10 to 24-year-olds, but increases in all other age groups. For race and ethnicity, we saw decreases among American Indian Alaska Native. However, as we saw before, that population has the highest rates overall, and the trend in the last 10 years was a increase for that population. And then we see increases for all other race ethnicity groups, with the highest being among Native Hawaiian or other Pacific Islander populations. On slide 17, I want to talk a little more about some populations that we know face some disparities in suicide rates. And I'm going to walk through each of these populations. Veterans, we know have an adjusted suicide rate that is 57% higher than non-veteran populations. Veterans account for 13.9% of all adult suicides in the U.S. We've talked about our American Indian Alaska Native populations, our tribal populations, and it's a leading cause of death for that population. It's the 9th leading cause of death, where for the U.S. overall, it's 11th or 10th, depending on the year. Suicide rate among male, non-Hispanic American Indian Alaska Native individuals that are in age 15 to 34 is over 82 per 100,000. We know that there are disparities and differences by age. Adults, that age group 35 to 64, account for over half of all suicides in the U.S. But we also know among our youth and young adults, they have a lower suicide rate overall compared to other age groups. But we've seen large increases, as we've discussed earlier. Moving down to the bottom half of the slide. While data are limited on rates of suicide among people who identify as lesbian, gay, or bisexual, research shows that high school students in that group attempt suicide at a rate that's 5 times those who identify as heterosexual. In 2021, more than 25% of students that identified as lesbian, gay, or bisexual reported attempting suicide in the past 12 months. The next group I'd like to talk about are industry groups. We know that certain occupations, folks involved in certain lines of work, have differing rates of suicide. The highest rates that are identified are among those involved in mining, oil and gas extraction. And for males, the rate is 54.2 per 100,000. The next couple of groups are males involved in construction, over 45 per 100,000. Those involved in services such as automotive repair and other service occupations, 39 per 100,000. The fourth highest is agriculture, forestry, fishing, and hunting. Males have a suicide rate in that occupation over 36 per 100,000. The final group I'll mention, occupation, is those involved in transportation and warehousing. The rate is 29.8 for males per 100,000, and for females is over 10 per 100,000. The last group I'll mention on this slide are people with disabilities. Adults with disability are 3 times more likely to report suicidal ideation in the past month compared to those without disabilities. That percentage is 30.6 compared to 8.3. And this is, again, among the U.S. Overall. And the reported rates of mental distress for people with disability was 4.6 times higher than those without disabilities. The last slide that I want to talk about before we move into some Kansas-specific data is looking at the map of suicide rates by state. On the right side, you'll see the ranks, and in this case, 1 is the lowest, is that's New Jersey with a rate of 7.1 deaths per 100,000. And the states I've included are our neighbors, or close neighbors in our region. And you can see Kansas comes in 33, so we're near the lower quartile of states, and rate of 19.4 in 2021. Our rate is just higher than Missouri and Iowa. Nebraska, our neighbor to the north, is at 15.0, and Oklahoma and Colorado have higher rates than Kansas. And you'll notice there's some clear geographic and regional differences in the U.S. in suicide rates. Our mountain and plain states, including Kansas, see higher rates of suicide. And many of those states are also rural. So the highest rate of suicide is found in Wyoming at 32.3, and it's followed by Montana, Alaska, and South Dakota. we'll now move into talking about a couple of our recent projects and work we did focusing on youth and on urban-rural disparities in Kansas. The first one I want to talk about is urban-rural disparities and differences in suicide rates. We published a brief on this in 2021. It's available on our website, and the picture should be linked as well if you would like to find it. Just briefly talking about how we did this work. We used data from Kansas Information for Communities, which comes from KDHE, and we looked at 20 years from 2000 to 2019. We used the age-adjusted approach that adjusted to the 2000 U.S. standard population. This is a typical approach and that's used to compare rates over time as populations change. The rate that we'll see is per 100,000, as has been most of the presentation. We aggregated data to 5-year periods. We did this because among some of our populations, the sample size is pretty small, and this allows us more ability to accurately describe the trend over time and be confident in the differences we do see. And the final note here is that we use KDHE's peer groups. And if we go to the next slide, we can see a map of those peer groups. So there are many ways to describe and categorize rurality. Many national approaches are simple urban-rural splits. If you do that for Kansas, most of Kansas is in the rural group. And so the approach we took was to try to have a little more granularity with our populations and our level of rurality. And these are those groups that you see on the map. So the groups in the counties in white are designated as frontier. They have less than 6 people per square mile. You'll notice most of those are located in the western half of the state, except for a line of those counties between our southeast cities and towns and Wichita. The next group up that is slightly larger is our rural designated counties, and those are the ones in blue, the light blue. The final group that is often included as a rural group are those densely settled rural counties. Those are the ones in green. In the western side of the state, it's Finney, Ford, and Seward County in the southwest, and then Ellis and Barton County in the central part of the state, and then we see some in the northeast and around Wichita as well. The final 2 groups are semi-urban in red, and then our urban counties in yellow. Shawnee County, Douglas County, and then the 2 or 3 Kansas City metro counties are all urban, and the only other urban county we have based on this designation is Sedgwick County. So when we describe the rates by group, you can keep this map in mind to know which parts of the state we're describing when we talk about those rates. You can go ahead to the next slide. So here's a figure from our project, and this is looking at suicide rate by peer group from 2000 to 2019. So this is 20 years. Over that 20 years, we saw the suicide rate rise from 12.5 per 100,000 in the first 5-year time period up to 18.1 in the final 5-year time period. This is an increase of over 44%, or nearly 1.5 times higher. We saw rates rise more quickly after around 2007 to 2011. And the suicide rate in our final 2 time periods was significantly higher for every single peer group than where we started. Said another way, we saw a significant increase for every single peer group. We're going to talk some about how they differed, but a key point is that we saw a significant increase across the board for all across the state. You'll notice in the color version, the peer groups that are rural are in yellow. while our urban groups, semi-urban and urban, are in black, and then Kansas overall is a gray dotted line. So I want to focus now on those yellow lines and the yellow groups. You'll see pretty clearly the group at the top with the highest rates, especially in the last half of the decade, is our frontier counties. And the increase among our frontier and our rural counties, the two most rural peer groups, outpaced those in all of the other groups. For frontier counties, we saw a 54.7% increase, and for rural counties, we saw a 59.4% increase. This was compared to increases in the 40s for our other peer groups. The increase in frontier and rural is also interesting if we move to the next slide, and we'll look. The second thing we did in this group is looked at suicide rates by means, and the chart you see here on slide 23 focuses specifically on firearms. And we've talked about nationwide that we know firearms make up about half of all suicides. This chart looks at the same peer groups, but specifically at rates by discharge of firearm. We see that for our frontier counties, it has been higher than the urban counties specifically every single time period that we looked at. So if we compare our most rural and our most urban, we see a significant difference in suicide rate over the entire time period. Beginning around that 2011 to 2015 period, which is sort of in the right third of the graph, we can see the rate of suicide by discharge of firearm for our frontier counties really increases. They stand out on the map, or on the figure, excuse me. And their rates of suicide by the end were significantly higher than all other peer groups. I think that it's important to point out our rural counties, by most metrics, are very rural, and by population density aren't that much bigger than our frontier counties. If you had asked someone from either side of the coast, they would probably not differentiate much between rural and frontier counties. They're all pretty rural. But what our data show is that there's something different going on in our frontier counties when it comes to suicide by discharge of firearm. Unfortunately, our study can't describe or point to exactly what is different, but the chart is pretty clear that our frontier counties have a increased challenge with suicide by discharge of firearm, even compared to those counties that are only slightly bigger. The last chart that we'll look at here for this study focuses in on that last 5-year time period. So this is 2015 to 2019. And each of these bar charts in blue on the bottom is the rate of suicide by firearm, and in gray is by other unspecified means. So on the far right, you can see Kansas overall in this 5-year time period, and it's about 50%, a little over 50% for discharge of firearms compared to other unspecified means. And that is similar for all of the peer groups except for our frontier. That is the group on the far left. And for this group, 66.8% of suicides were by discharge of firearm. So nationwide, we see it's about 55%. For suicide deaths in our frontier counties in Kansas, in that 5-year time period, it was 2/3 of suicides were by discharge of firearm. I'll now move to the last part, and I check the time. I think we're okay. So this is the last section. We'll talk about our other project and our other study. And this one focused on youth. You've already heard about challenges we have with youth suicide prevention and youth suicide rates. And this will give another way to look at that data. And you already heard about and saw some slides from Lauren Gracie, but Lauren Gracie helped us some with this work as well. We took a very similar approach methodologically. We were looking at trends and we're using 20 years of data. This is 1 year step forward, so it's 2001 to 2020, where the rural frontier was 2019 was the most recent year. And again, we're aggregating to 5-year periods and looking at rates per 100,000. You can move to the next slide. So I'm on slide 26, and we see a map, rates of suicide, again, per 100,000. And our age group that we're looking at is 15 to 24 year olds. At 21.5 suicide deaths per 100,000, Kansas had the 10th highest suicide rate in the nation for youth age 15 to 24 in 2016 to 2020. That's our 5-year period for this map. Kansas also had the 11th highest suicide rate for early adolescents. That age group in this fact sheet was 10 to 14. That's not shown on the map, but is included in that resource. During this 5-year period, 2016 to 2020, suicide was the second leading cause of death for both early adolescents and for youth. And this is a general finding we see nationwide as well. Youth, young adults die less often from other causes, so suicide is a higher cause of death compared to other ages. Move to the next slide, slide 27, and we see a familiar bar chart, or line graph, sorry. Each of the bars, the shading, is giving you some visual indication of that 5-year time period. And this looks at the past 2 decades. We see suicide rates in Kansas, which is in the blue, and the U.S. is the lighter of the two. Kansas is the darker. You can clearly see that Kansas has had a higher rate of youth suicide than the U.S. overall, and that difference has not decreased and has not gone away. For both U.S. and Kansas overall, we saw increases, but that increase was more rapid in beginning around 2014 to 2018. That's the sort of the third to last time period. We saw a 63.8% increase in youth suicide rate for Kansas compared to a 41.4% increase for the U.S. overall. So we were higher, we remain higher, and we increased faster. Last chart here, I know I've given you a lot of data and a lot of numbers. Last chart here, this is our bar chart, and we're looking at rates of suicide for that same age group, 15 to 24, but we've broken it out into male and female. So we see male on the left, female in the middle, and then combined on the right. The suicide rate among male youths in Kansas for this time period was higher, 32.7 overall, compared to 9.1 per 100,000 population. So the other thing I want to point out and see in the charts, we see higher rates among males compared to females, but if you look at the means, there's a switch. Among males, discharge of firearm was a higher rate, where for females, it reversed. For male youth, suicide by discharge of firearms was more than 1.5 times the rate of other unspecified means. For females, suicide by discharge of firearms was 1/3 the rate. So that's that switch. That's the last slide I have for you. I see we're right at the end of our time.
We're right on time. Committee, do we have questions for Wyatt before we lunch? Seeing none, thank you so much for being with us. And I just got the heads up that our lunch is ready. So committee, we will be having lunch, and then we will reconvene at 1 o'clock. You're welcome to bring your lunch in here. Yes. Okay.
Thank you. I was thinking you were coming back. Your presentation was excellent.
Thank you.
And I think it was even the voice just kind of went right across with it, but it is a sad scenario though.
It is.
But thank you so very much.
Thank you for the opportunity to share. And my contact information is in the slides. Don't hesitate to follow up with any questions. I know it's a lot of information to sift through. Thank
And
you.
and before we go to lunch, we have a quick question from Senator McGinn.
Thank you for your presentation and the others who presented as well. I'm really not surprised by the outcomes. We've been looking at that for the last few years at least anyhow, but at an increasing rate, unfortunately. I guess one of the things we were talking about is we would like to hear more in the future what is causing the trigger, you know, and why are these trends increasing and what are the solutions? And I don't think we're hearing much of that today. We're seeing really hard facts of what's out there, but I hope that there is some research done in that area.
Yeah, thank you for the question.
Thank you, Madam Chair.
We know, as others have said, that it's a very complex challenge to try to untangle specific causes. We know a combination of stressors and risk factors combined with unmet need is often part of understanding why, but it's really challenging to point to specific causes. But I've written down the question. I appreciate it.
Just one other follow-up of interest, though. I noticed, if I remember right, that 28% leave a note, leave a letter. And, I mean, that's a pretty high percent when you're ready to waste your life. And it'd be interesting what is in that letter. Is it resentment? Is it, you know, what is it? And can something be learned from those letters? But I'm sure they're very private. You know, families aren't going to just put them out there. So, thank you.
Thank you.
And I think you would agree that research is only as good as the data that's available. Yes, Representative Blex.
Yeah, I would agree that we need to focus not so much on the tool as we do the reason. The reason is what caused people to pull the trigger, so to speak. And sometimes we get overboard of thinking that if we take away the tool, that's going to solve the problem. And studies have shown that isn't the case. So certainly it doesn't surprise me with rural Kansas having access and every home having firearms doesn't have, you know, that's an issue. But as a kid, I grew up with firearms all around. Every truck, every pickup truck at school, we even took them on the school bus. Nobody thought of shooting anybody else. It was so rare. So there's another reason, and that it's just not the tool. There's other reasons underlying this thing that are causing it. So I would like to, you know, that's more important to me. Thank you for your report.
One follow-up comment. I know we're
Yes.
about to go to lunch. Part of why there's a lot of attention to means, and particularly with firearms, is some research that we do have. We know that the time period between a decision and acting on that decision can be really brief. And when the means are very lethal and the time between deciding and acting is very quick, then the lethality of those means and the ease of access to those means to act on that decision become a way that we can think about prevention while still working to understand why and understand how can we prevent them from getting to that point. But that's part of why there's a lot of attention on the means.
Again, I'm sorry. Thank you so much for being here. And we had a question from Senator Holscher. Senator Holscher.
Yes, thank you. Thank you, Wyatt, for the presentation and the information. There was, you know, you had that one slide in regard to disparities, and there was something that I wanted to mention, and I'm curious if the area of second generation immigrants has been looked at as far as a disparity here in Kansas, because it's something that we kind of tripped upon here in Johnson County in regard to the population. Here in our Olathe School District, we have a large number of students who are second generation immigrant that have some struggles in regard to the stigma they face being children of immigrants, and then also just the stigma of reaching out for mental health care or for help for mental health care. And I didn't realize that that was such a huge area in terms of mental health issues. And it made me think about, like I said, the large population that we have that are second generation immigrant here in Johnson County. And then I would imagine also in Garden City and some other areas probably have that same type of situation with a larger population base that are second generation immigrant. And I was just wondering if there's any research or any information being collected in that regard.
Unfortunately, I don't have any of that or know of that, but I appreciate the comment. I've written that down as something for us to think about.
Okay, great. Thank you.
Thank you. Committee, we do have boxed lunches from the Pennant that's provided and sponsored by the Kansas Association of Community Health Centers. We are in recess until 1 o'clock. I'd like to welcome to the microphone. Okay, committee, if you would refresh your legislative site to get Sonia Bacchus's testimony. And Sonia, would you come forward, please? Thank you so much for being here. Sonia is the CEO of Community Care Network of Kansas, the federally qualified health centers update.
Vice Chair Landwehr, thank you so much for making the time for us to share some perspective from the side of Community Care Network of Kansas and the federally qualified health centers and lookalikes that we represent. Just very briefly, Community Care Network of Kansas is the state's primary care association of community-based primary care clinics, mostly made up of FQHCs and lookalikes, but we do have some community-based clinics. We have about 32 members, and in 2022, more than 332,000 patients were served for more than 1 million visits. And so we see a lot of patients across the state of Kansas and are a key part of the primary care system in Kansas. Some of the key features of FQHCs you heard a little bit about yesterday. We're organized under Section 330 of the Public Health Service Act. We're designated by the Bureau of Primary Health Care, and we do have to have community members and patients on our board. 50% of the health centers boards must be made up of, 51% must be made up of patients. So we do have the patient perspective in our decision making. We have a sliding fee scale for all self-pay patients. Even our insured patients can get some sliding fee scale benefits if they qualify per income level per the federal poverty guidelines. We see all patients regardless of ability to pay. That is a part of our requirements. FQHCs must they must follow the 19 program requirements set out by the Bureau, and one of those is that we see all comers who need our care. We're also able to purchase discounted drugs under the 340B program, which helps health centers with programs and lower costs for patients. The key features of the lookalikes are that they are very much the same as FQHCs, except they don't get the federal funding that comes along with lookalikes. So when there is an opportunity for expansion or new access points through the Bureau of Primary Health Care, that's when those lookalikes can actually apply for and start receiving, if approved, the federal funding. If you look at this slide, this just shows where our member clinics are across the state. And so we serve in all areas of the state. As with the community mental health centers and some of our other providers, there's a larger concentration in the northeast through the southeast side of the state, but we do serve across the entire state. When you look at our payer mix, you can see how our reimbursement runs. About almost 11% of our patients have Medicare. A little over 30% of our patients have Medicaid. About 29% have private insurance. About 29% are uninsured. So we do utilize that sliding fee scale quite extensively. In 2021, we wrote off in our FQHCs and lookalikes more than $50 million in sliding fee discounts and bad debt. And I will thank both the House and the Senate for approving $3 million in additional funding for our health centers to at least offset some of that major loss. Our members provide a number of types of health care. Of course, we provide medical care, and about 68.5% of our visits are medical. About 18% are dental. Just about 1% in the 2021 numbers were vision. That number is increasing as our health centers add vision care and optometry services. About 10%, or just over 100,000 of the 1 million visits, are behavioral health visits. And I think we heard a lot yesterday about integrated care. And integrated care is research shows that integrated care addressing both physical and mental health needs are going to always improve health outcomes. And so what we believe is that community health centers that provide primary care should integrate behavioral health into their services. We believe that CCBHCs should help the primary care help with the primary care needs of their patients. And so we are excited about some of the things that we do to partner and excited about the opportunity to partner more with our community mental health centers and CCBHCs. Some of the ways that we're addressing mental health, specifically in our health centers, are through integrated care models, where in some cases, right in the pod with the medical providers, you'll have a psychiatrist and/or a therapist or a counselor who is right there, who can be called on when patients are with their primary care provider if they see a need. Primary care providers do some of the medication management, but as things get more complicated, of course, those patients are funneled onto the mental health provider and the prescribing providers. We are really excited that just last week we learned that a project that we are partnering with KDADS on was approved. That project, in partnership with KDADS, 5 of our health centers were selected to apply for federal funding through SAMHSA that would allow for more work to be done around integrating primary and behavioral health care together. And so we do have 5 health centers that are going to be benefiting from that. And again, we just got the announcement, I believe it was last Friday, that those funds are there. It's a 5-year grant cycle that is somewhere around $2 million a year that's spread between those health centers and then our KDAD's office so that they can have the support that's needed to help support the health centers, and then a very small amount to community care for our participation in the work that we do in coordination and support. In terms of school-based health, of our 21 FQHCs and lookalikes, there's 174 total sites, and 69 of those 174 are listed as school sites, many of which provide both medical and behavioral health care. And I don't have an exact breakdown of that, but we're working on getting that data. But we are in a number of schools across the state providing care. On the Mental Health Intervention Team program, the MHIT program, Atchison Community Health Center was asked by the Atchison School District to participate, and then Community Health Center of Southeast Kansas does participate in 2 counties in the MHIT program. As Senator Baumgartner shared yesterday, the final rule that came out was right around the same time as the deadline for school districts to apply. So not many of our health centers that would have been interested were able to this past year, but we do look forward to having more presence in the MHIT program going forward. As I shared earlier, and Representative Carpenter, you stay on us about the collaboration that we have with our community mental health centers. And this next slide talks about our Delta Center grant. The Delta Center grant has been in place for going on 3 years now. And with this grant, the Community Mental Health Center Association, under Kyle's leadership and then my predecessor's leadership, worked together to submit for grant funding to look for ways to better collaborate. And so that grant has allowed us to have many collaboration opportunities, to see nationally different models of collaboration among community mental health centers and/or CCBHCs and FQHCs across the country. So we were just in April at a conference where we got to see a lot of different models and things that we can model from, and that they were able to see some of the things that we've done. The purpose was to, again, drive collaboration, and then pursue policy, payment, and practice changes to advance the integration both on the mental health center side and in FQHCs. We now better understand each model and the challenges of each type of organization. There's exploration around care coordination, lots of encouragement for local dialogue so that the community mental health centers and FQHCs are doing just what you talked about yesterday in terms, and what we've talked about even before then, in terms of working together and not having tons of overlap. I don't think we can get away with doing the work that we're doing without any overlap, but I think that we really can have an efficient and strong system working together. And then also some shared data collection so that we can really document what the outcomes are of integration. So we had the grant for 2 years. They did allow for a third year. It's not as much funding for year 3, but we did apply for and we're accepted for a third year. So that is helping to support our work together and on further collaboration. And we do know that, I want to pull this up on my iPad real quick. I don't have this one printed, and share just a couple of examples of collaboration that we have across the state. We have a couple of our members have co-located sites. So Grace Med has co-location with ComCare. CHC SEK has some co-location with Fort County Community Mental Health Center. Vibrant Health and Wyandotte Behavioral Health Network, their CEOs work very closely together. And actually, when I was working for one of the health centers in Kansas City, we also worked very closely with Wyandotte Mental Health on the Kansas side to make sure that their patients had primary care as needed. And so in Manhattan, I was talking with Danny Halgren at Kanza. They are partnering with the Community Mental Health Center there as they go into their CCBHC work. So these are just a few of the examples of collaboration. And as you have stated, to ensure that we are utilizing the state's money and Medicaid dollars the best that we possibly can, most efficiently, and having as much cost savings as possible. We do believe that collaboration is the way for us to continue to make these models work. And I now stand for questions if there are any.
Representative Carpenter.
Thank you, Madam Chair. Sonia, thank you for that. So as a layperson out here that probably needs more mental health care than about anybody else, walk me through the collaboration type. What would happen? Patient comes in. How does that work?
So in practice, I don't have the specifics of how those practices work in terms of like the day-to-day operation, but how it's been done in my history is, in general, most of the time, there's specific contacts in each location that are able to make those contacts. So, for example, a patient comes in with primary care, and maybe it's a health center that doesn't have as much availability for behavioral health services, or they have patients with higher acuity levels that would need the community mental health center. In most of the time, the collaborations work in a way that there are specific contacts in each location that are able to cross-refer and coordinate and ensure that the patients get what they need on either side. And, you know, I have this model in my head. If I were still on the health center side, I have this model in my head where if a patient comes in for behavioral health care at a community mental health center and they don't provide primary care, which I did learn something yesterday when Drew gave his presentation. I have always, based on the information that I've read and the conversations that I've had and even webinars and such that I have gone to, had interpreted the requirements for the CCBHC to actually directly provide the primary care. And you talk about overlap and duplication of services, and I always had that in my mind, but I was always thinking the model that I would be pursuing is if I were a CCBHC, and couldn't provide primary care, especially at the PPS rate that, makes it easier to take care of patients who have so many needs. I'd be working to have a relationship with the health center that would ensure that if I had a patient who needed primary care services, I'd want to be able to pick up the phone and get maybe a telehealth visit right away, just so that we could get the patient's immediate needs taken care of and then get them into care. Or I'd want to co-locate so that we could cross-refer right there in the same building. And again, some of our health centers are already, and CCBHCs are doing that. But that's the kind of model from an operational level that I would be pursuing.
Very good. I'm glad to hear you say that. So, Madam Chair, could I just, so 340B program, you touched on a little bit, money maker for you. Can you talk a little bit on that?
Absolutely. So 340B does allow a significant amount in some health centers. And, 340B is under attack from many different levels right now, particularly pharma and the PBMs. But so some of our health centers are losing a lot of the dollars that they used to be able to bring in for 340B. But with the 340B dollars, every single one of those dollars has to be accounted for in how it has been used to reduce cost for patients for their drugs, or additional programming and services. So some of the mental health services that we, on the FQHC side, that can't be billed for example, and be reimbursed at PPS rate because of certain designations that of healthcare providers that are not yet able to bill PPS rate. Some of those dollars go to offset the cost of those providers. Some of those dollars go to add additional staff, add additional program, do transportation. And so, but every one of those program income dollars have to be reinvested back into the patient and her services. So it is not a profit moneymaker.
Oh, I understand that. And there are really no guidelines on how you can spend that. You can buy a building, you can buy capital improvements. There are no federal guidelines on how you can spend the profits of the 340B program.
Yep, they just have to be invested in ways that will support patients.
Right.
Absolutely.
So, okay, very good. Thank you. Thank you, Madam Chair.
Representative Landwehr.
Thank you, Madam Chair. On your, I don't see numbers. On the types of care provided by member clinics, that little chart there.
Yes, ma'am.
You had the medical, dental, vision, and behavioral health. Do you get PPS on all of those?
PPS on medical, yes, medical, dental, and behavioral health do have some PPS. And for behavioral health, it depends on the provider license designation. Some of the providers are not able to bill at the PPS rate. They're just able to bill at fee for service.
Okay, and Sonia, when you say providers, are you talking about the individual clinics, or are you talking about some of the licensed staff within the
licensed
clinics?
staff.
Okay, so some of the staff, depending upon what their classification is, can bill PPS within the FQHC on behavioral health?
Some
Okay.
can, yes.
Senator McGinn?
Just a quick question. I'm not tracking on your first slide that has the state. What are the numbers representing? What are the numbers? What do they mean?
On who we are, on the one that talks.
The member clinics, so like Harvey County, you've got a 15 there. Does that mean there's 15 clinics?
Oh,
or
no,
what does
ma'am.
that mean?
No, ma'am, this is just counting up from 1 to 32 members.
How do you decide who gets to be number 1 and who gets to be number 32?
Actually, it's just in alphabetical order, I think.
Okay. I was curious. Thank you.
Yes.
We're number 1. Committee, no. No, I know. Do we have any questions, any other questions for Sonia, committee? Sonia, thank you so much for coming, and that gives us some more information directly from those who provide the care.
Thank you, Senator Gossage.
Next, we're going to welcome Kyle Kessler to the microphone, and he's the Executive Director of the Association of Community Mental Health Centers of Kansas. Welcome, Kyle.
Thank you, Madam Chair, members of the committee. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We represent all 26 licensed CMHCs around the state. We appreciate very much the opportunity to be here this afternoon and share some comments about really the status of the CMHC system as well as the incorporation of the CCBHC model into it. I'll be pretty brief with my comments and because I want to save plenty of time for question and answer. And I know the members of this committee have served either on budget committees or health committees, and so you all have a pretty good working understanding of what our system does. And even as I was thinking this morning, I was telling a legislator at lunch that I think I reworked my comments maybe 3 times. First, to start out by talking a little bit about history and information to update that, then to really kind of give a cold, hard look at some of the challenges and difficulties that we're seeing across the state. And then after 2 hours of discussions relating to crisis services and suicide, I thought maybe to go for something a little bit more on the hopeful side might be a good direction, and to think about sort of where we have been and where we are and where we're going is what I want to do with this. And so with the Mental Health Reform Act of 1990, that was passage, of legislation that was really landmark for Kansas. And what we wanted to accomplish out of that was certainly to recognize that Kansas is proud of its state-designed and state-defined system. And there are other states that we work with closely in that regard as well. The county-based connection between mental health centers with kind of a shared governance between local partnerships and counties and the state government is a big part of who we are. And so when you look at the way that mental health reform was supposed to work in Kansas with deinstitutionalization, the closure of state hospital beds, us now having about a little less than 25% of the overall state beds that we had in 1990, and then shifting that funding to community-based services that were going to be robust outpatient and preventative treatment. It started off as kind of a state keeps $1, state gives $1 to CMHCs. Then it went to state keeps $2 and state gives $1 to the CMHCs. And eventually we got to a place where it was about $5 to the state, which would go towards other expenses or tax relief, and then $1 to the CMHCs. Eventually that system was bound to break. And in 2016, that's what we saw happen. And so even during that time, and what we know is really over a 3 or 4 year period. It was a system in the breaking. And so to rebuild that, how we started to in 2017 to where we are now, it still is a project in development, I would say. And so when we look at all of the different things that are coming at our youth and our veterans since 1990, we have had a war right out of the gate with Desert Storm, and then Operation Enduring Freedom, Operation Iraqi Freedom, the advent of email and the internet, the attacks on 9/11 in 2001, and the war in Afghanistan, then social media, then a pandemic, and now more social media. So I know you're thinking, and this was his hopeful version of his presentation. That's not a feel-good, Kyle. I get that. And so I think that what we see, and what I was thinking about even as it relates to the conversation relating to youth suicide, is the evolving nature of this. And to Senator McGinn's earlier comments, as I was listening, we started seeing after 3 or 4 years, right before the pandemic, because those numbers come out a year or two later, and right before the pandemic, we started seeing this tick towards the positive for our numbers. And so you kind of thought, man, some of the prevention stuff we're doing, putting more money back into the CMHC system is really making some progress. And so we're again seeing how those things evolve. And the comment made by Representative Ballard about youth and being able to go home on the weekend and kind of recover, and now you don't get a break from that. And oftentimes, and I can remember that being young at one point in my life, that sometimes you were trying to get to the end of the week so you could go do whatever your own thing was and be away from a crowd at school. And now there is no getting away from it for youth. If they have a phone, if they have a computer, if they have a friend who has a phone or a computer, you are constantly getting your bell rung, so to speak. And so oftentimes your weekends end up being the loneliest because you know what's going on. And just to add on to this a little bit more, it's not an accident that the last two surgeons general, under both President Trump and President Biden, respectively, are talking about an epidemic of loneliness and what that does to your body physically. They are comparing it to smoking packs of cigarettes a day and drinking a fifth of vodka, and what it does to your nervous system and your regulatory system. And so these are things we haven't really thought this way before. But I think that with the CCBHC system, and now with us having 20 out of 26 of them being certified, we'll see another one in October, probably a couple more in January, and so still be on pace to finish this out. I think that most states, and I was at a gathering of my colleagues this last weekend in Denver, and one of the things that I would highlight to you all that I appreciate your support on this model so much about, as much as, you know, with the Mental Health Modernization and Reform Committee, we really leaned on what some of the early lessons were from Texas and Missouri, and how that has even evolved. We were getting credit at this meeting that I was at from Indiana, Nebraska, West Virginia, who have all passed what they are referring to as Kansas-style legislation, and then going next to, we think, Montana and Alaska. So that's something that I think that we can be proud of as a state and as a system, and we want to continue that model going in the direction that it was intended, to make sure that we also have as much opportunity to put time and effort into prevention-oriented education. So those things like mental health first aid and applied suicide intervention skills training. And Department of Corrections, I know, was one of the things that was on Commissioner Brown's list of recommendations that the Mental Health Modernization and Reform Committee put together a couple years ago. And Department of Corrections took that seriously. They contracted with our association. And in fact, Sue Mernan, who was here yesterday as part of the roundtable, coordinates those efforts around the state. And so we are probably as active as any state right now in the country in trying to do mental health first aid with first responders and educators. It's something that I think helps educators fulfill their requirements under the Jason Flatt Act. And so we really are trying to look for every opportunity to get the prevention message out there and get people connected with treatment at their first signs of anxiety and depression. The last comment I would make at the moment would be that Dr. Tom Insel, who is regularly referred to as, or used to be referred to as, America's psychiatrist, because he was the executive director under the National Institute of Mental Health under both President George W. Bush and then for several years under President Obama, talks an awful lot about how going forward he sees, you know, the future look, but he really focuses on the youth. And a couple of the statistics that he cites is that from the years 2016 to 2021, the prevalence in depression and anxiety went up by 29% and 27% to students. And so my first reaction when I heard that was thinking, wow, that seems really low. But the fact that we're now citing those kind of statistics and being up near 30% in those increases means that we've got a bit of a five-alarm fire, and we know that. But the hopeful side, which you had to be thinking eventually I would get there, is that it's amazing to me how the youth today can talk about mental health issues as though it's a broken arm, whether it's talking about what their therapist says or what their psychiatrist might have mentioned as a way to help alleviate symptoms of severe anxiety or severe depression. And so I think that one of the other things that Dr. Insel really talks about, as we talk so much about stigma, he says that the time for that has passed, and we need to call it what it is, or what it has been, which is discrimination, because we've talked for too long about how disorders of the brain are so much different than disorders of the kidney, the heart, the lungs, or any other organ. So that makes a lot of sense to me. I think we may start adopting some of that language. We were pretty early on adopters of even referring to our clients or consumers as being patients, because it's part of healthcare. So I think that with that, Madam Chair, I would conclude my comments and stand for questions at the appropriate time. In the event that there is an operational question about CCBHCs or crisis services that the committee and the committee members online may have, then I did also ask Tim DeWeese, the Executive Director of Johnson County Mental Health, to attend the meeting today, so I can phone a friend as necessary.
Representative Landwehr.
Thank you, Mr. Chairman. This isn't for you. I'm glad that you brought Tim up. If you wouldn't mind stepping up to the mic, I'd appreciate it. Good.
Yes. Thank you.
If you would introduce yourself for
Yeah,
the
Tim
people at home.
DeWeese, Johnson, the Director of Johnson County Mental Health Center.
All right, Tim, we heard yesterday, and you kind of got called out a little bit, that you weren't able to provide all of the necessary services, and I'd like to hear your feedback on that particular comment.
Certainly. So there's a lot of times that when I speak to our community as a whole, I outline the issue within Johnson County. So if you look at Johnson County and you look at the population of roughly 650,000 people, and you look at the total occurrence of mental health conditions, that's roughly 108,000 people that could benefit from mental health services. So could Johnson County Mental Health Center provide services to all 108 of those individuals? Absolutely not. But when we look at specifically services for those individuals who have a severe persistent mental illness or serious mental illness, and those kids and families who suffer with a severe emotional disturbance, those are our wheelhouse. That is what community mental health centers, that's what CCBHCs are all about. And for those individuals within Johnson County, we're able to serve all of those folks. Do we look for community partners to serve individuals that are needing outpatient therapy? Absolutely, and we have a ton of those, including our FQHC locally. But we serve those individuals that have the most severe and persistent mental illnesses. We serve them all. We have no waiting list. We do same-day access. A person accesses services the same day that they reach out to us. But if they have maybe a less level of care, then we're going to look for one of our partners to do that.
And I haven't kept up with who's online as a CCBHC. Are you a full CCBHC now?
We are, yes.
Okay. And then you're also one of our 988 call centers, correct?
We are. So, and just so you know, we'll reach over 40,000 calls by the end of this year.
Okay. Do you know off the top of your head? If you don't, that's fine, because I hadn't necessarily expected myself to take it that way. Is what your call answer rate is?
Ooh, I don't
That's
off
fine.
the top of my head, but I will look that up and get it to you by the end of the day.
Well, Andy's giving me a thumbs up, so he must think you're pretty good back there. Do you
Yeah,
have those numbers, Andy?
I think we raised the state average.
Okay, now you're into fighting words. I'm just saying, because you know where I'm from.
Well, we help. How about that?
Okay, thank you very much, Tim.
Yeah.
I appreciate it.
Thank
And
you.
then Kyle, a question for you. Out of our CMHC, CCBHC, they all kind of go together now. How many of those are county-owned and why?
Of the CCBHCs, so of the overall.
CMHCs,
yeah,
it doesn't
okay.
make a difference.
And I can say both. Of the CMHCs, 23 out of the 26 are private not-for-profit organizations, 501c3s. The other 3 are parts of county government. Johnson County, where Tim's from, ComCare, which is Sedgwick County, and Crawford County down in Pittsburgh area. So, and I think each of them has had probably different reasons for retaining or being county-owned and operated. But of those 3 that are county county operated at this point. Johnson County and ComCare are both full CCBHCs, and Crawford County will be the other one that should be certified, we're hoping, in October.
Okay. And then I just want, and this will be my last, I just want to kind of get maybe a little bit better understanding, because I know that you touched on it, is the part that was put onto CMHCs at the time Topeka State Hospital and Winfield were closed.
Topeka State Hospital, and then Winfield, later on Rainbow Mental Health as well.
Mm-hmm. But what was expected of the CMHCs
Oh, I'm sorry.
to step in? Because the money was supposed to follow the patient. I've never felt like that's exactly what happened.
Yeah,
So a little bit of history of you, yeah.
Okay, and it would be a lot less money that would have followed the patient, but the idea was that each mental health center, and Tim can probably shed more light on this, but the idea is that the CMHCs by statute, and we are, I mentioned we're being state designed and state defined, and it really is all over Kansas statute books, but with that, the CMHCs are required to be available to anyone regardless of their ability to pay, be available for crisis services or crisis diversion, and they screen people into the state mental health hospitals. So they are, in effect, the gatekeepers, and I believe each CMHC has a liaison for discharge purposes as well. So when they come back to the community, because I think at one point our statistics showed that only about half of the people who presented for treatment at state mental health hospitals were actually known at that time to their CMHCs. So as we get that number higher under CCBHCs and have more proactive care, then we will know more of those individuals and be more able to divert them from care. Is that all fair?
Okay, absolutely.
Representative Carpenter, then Representative Blex.
Thank you, Madam Chair. Kyle, thanks for being here.
Thanks.
So a lot of counties fund they put in a portion. It may not be county-owned.
All 105, yes.
Yeah, but they still put in money to their.
That's right.
So, yeah, I just remember, I thought ours was county-owned, but I know when I was a county commissioner, we always put money in to our mental health center.
And I believe there is a requirement in statute that requires every county to contribute something, maybe $1,000, it may be several million. So, I mean, depending on the size of county, obviously, but all 105 counties still contribute to their local CMHCs, and each CMHC is designated by their county as the CMHC serving that county.
Okay, and now for the hardest question you're going to have. So I see your name is Community Mental Health Centers. So now when we get them all changed over to CCBHCs, are you going to change the name of your organization?
Mr. Chairman, that sadly has been asked of me many times, and several people have asked me if I was working my way out of a job, and it totally stumped me when they were asked the question. But how many teams are in the Big Ten Conference at this point? How many are in the Big 12, the Pac-10, whatever? I think that we'll look at something like that. But the difference of the CMHCs as well, if whatever we change our name to, people are still going to call us the CMHCs.
Agreed. Thank you.
Thank you, Representative.
And I think what clarified it for me yesterday was that the CCBHC was a designation. So you are a CMHC with the designation of.
Yeah, absolutely, Madam Chair. And the idea being, and even as it's talked about regionally or nationally, the idea of serving people outside the four walls of the actual clinic.
Representative Blex.
Thank you, Madam Chair, and thank you, Kyle. I've been told that the CCBHCs have non-licensed people on their staff. I guess my question is the reimbursement rate for those non-licensed people on your staff the same as a master's level clinician, or is that on a per visit basis? Could you clarify a little bit of that for me?
Well, and very quickly, so that Tim knows that I'm going to defer to him in just an instant, I think it would be helpful to know the context of that, because I don't know if they're referring to case management staff or if they're referring to therapists. I mean, all of our therapists would be licensed by the Behavioral Sciences Regulatory Board. We've worked on some licensing language that helps relax a little bit of what we do so that it can help with our workforce shortage. And workforce shortage, we absolutely have. But in terms of the licensed or unlicensed staff, I think it probably helps. Do you know that reference?
I think, when we talk about the transition from just simply mental health care to behavioral health care and really looking at what we call the social determinants of health. So what we know is that while we may be working with someone that has a clinical diagnosis of schizophrenia or bipolar disorder, but they also are homeless, they are eating unhealthy, all those kinds of things. So we have a variety of services provided both by clinical and non-clinical staff. The beauty about CCBHCs is that we can ensure that we've moved out of a individual fee-for-service system, so an hour for an hour, and it would have been, in the past it was provided at a different rate. In this case, you are basically being able to be provided that rate, that per service rate, that prospective payment rate for the entire service that's provided in that touch. So in essence, it's moved us out of a hour to hour to hour to providing a service for an individual client.
So to clarify that, if a person comes in and talks to a professional clinician, and then they may refer down to a peer review, somebody who's been involved with substance abuse or something that may not have that same credentials, is that counted as at the same rate, I guess, is what I'm asking?
It would be counted as a different rate if you're looking at an hour per hour, so that peer support rate would be reimbursed at a lower rate than that hour of therapy or that hour of case management. Those are all billed differently, and that's based upon insurance rates typically. So those would all be different. It'd be based upon that level of experience, either clinical or non-clinical.
Okay, I'm just trying to clarify that because I've been told it didn't make any difference who they saw. It was the same particular rate, and that's what I needed to find out.
I think Tim would like it to be that way.
Sure. But, and Representative, I may actually, if it's okay, have Commissioner Brown also address that, if it's all right with you. Apparently, it takes a whole village to support me.
I just wanted to answer.
Yeah.
Andy Brown, Commissioner for Behavioral Health Services, KDADS. So I think we tried to address this yesterday, and I'll try to reinforce what we said yesterday. But under the CCBHC model, with the PPS rate, peer support's reimbursed at the same rate as any other service. So whatever PPS rate that particular CCBHC has, if the person comes in and they see somebody for family therapy, or they see somebody for group therapy, or they come in and get, it's an ACT outreach team or a mobile crisis service or a crisis intervention service, it all pays at the same daily rate, because all of those costs are included and then divided out over the number of encounters.
Like attendant care is not a trigger code.
Well, I don't want to get anybody confused about trigger codes today, but the PPS rate reimburses the same for each encounter regardless of what triggers that encounter.
Okay, so
Yeah.
I think I'm clear.
Okay.
Representative Ballard.
Seriously. All right. Someone asked about the name change, and I got to thinking. Now, CMHCs were established by the legislature.
Yeah.
Okay. The CCHBCs actually is not. Well, it wasn't established that way, because the CMHCs were established because we didn't have the services available and everything else. So even if there was a name change, I know it sounds weird, I have another question, but are we going to have to go through and make an amendment to that because they established these services? Now, we voted on CCHBC. But see, I think it gets really confusing.
It can, and all the licensure for the CMHCs is still through KDADS. The certification for CCBHCs is still through KDADS as well. So there still is a licensure structure through KDADS. So I was probably a little more tongue-in-cheek and a little less specific on that issue than I should have been. I apologize.
No, but that's what I was wondering, because I'm trying to think in terms of, is this the replacement for it?
It could be. I mean, we would still have all of the licensing requirements and the responsibilities of CMHCs would then be assumed under CCBHCs if we replace them with that. Does that make a little bit more sense? I mean, so right now, we hope that all CMHCs become CCBHCs, and but there's still two different designations. I felt him.
I felt him.
So, Andy Brown with KDADS again. I think the easy way to answer this and try to address this is that KDADS licenses under state statute for CMHCs. When we passed the bill that established CCBHC certification, that is a Medicaid certification, right? It's part of the Medicaid program. So that CCBHC certification is important for CMS and for billing purposes and the way the Medicaid program runs. But for all the other services, all the things that they're statutorily required to do, that CMHC license is still required. Does that make sense?
You don't know everything.
So we'll continue, like when we come out and do a certification visit, we combine that with their licensing visit. So we'll be doing their relicensing renewal for their CMHC and their certification for their CCBHC status at the same time.
Okay.
Yeah.
Thank you. That clarified part of it for me, because the more we talked about it, it was a little confusing as to what it is. I know what the payment is, but then what else happens? Okay, fine. I will move this one. I want to go back to another comment with Kyle. Kyle, I believe about 8 years ago, when we had a conversation about mental health, you were concerned about the high rate of mental illnesses and suicides, especially for teens in the state, because we made this an issue, okay? Now that we have come this far, and we had yesterday a town hall meeting and everything else, what is your feeling about the mental health issues that we're not only having in Kansas, but in general?
I think for me, and I was visiting about this quite a bit over the weekend, and one of the things the legislature has done really well is continue to look closely at this issue. I was writing down all of the, and I'm not trying to digress at all, but 2017, 2018, we had the Mental Health Legislative Task Force. 2019, the Legislative Budget Committee Mental Health Bus Tour that Senator McGinn helped engineer. 2020 and 2021, the Mental Health Modernization and Reform Committee. 2022, the Mental Health Beds Committee. And then this committee is the 7th committee in 7 years where many interim days have been committed to studying and discussing mental health. So I think that kind of to answer your question, one of the things that is really helpful for us to do, and something probably my most recent light bulb moment, for lack of a better term, was knowing that there are populations we're just missing, and that we need to do a better job of identifying and providing treatment and outreach to those populations. And my first thought of that had to do with veterans, because it's one of the requirements under CCBHCs. And knowing that Fort County Mental Health saw a nearly 30% increase in the number of veterans they were seeing just because they were able to go outside the four walls, had someone on staff who was a case manager, would go down to the VFW, and then someone might say, I'm doing okay this month, but Joe's really having trouble with the withdrawal from Afghanistan. That has triggered him, and we're really concerned about him with his PTSD. So it may also be people in certain geographical areas, different peoples of color or ancestries or things like that. So I think that for us to really improve what we're doing and really see our numbers come back down quite a bit, we need to identify the populations and figure out how to get them the treatment they need, where they need it, and when they need it.
Okay. Thank you very much, Madam Chair. Thank you.
Additional questions, committee? Seeing none, Kyle, thank you so much for being with us today and for this presentation.
Thank you so much, Madam Chair.
Next, we're going to move to virtual care. We saw in several of the presentations today, it included telemarketing, anything but telemedicine. And this is Mark Johnston, and he is with, is it Aval eCare?
Avel, short.
Avel eCare.
Avel, yes, ma'am.
And it's short for what?
I meant phonetically, it's a short A.
Phonetically, it's the short A.
Yeah.
Avel eCare. Mark, welcome to committee.
Thank you, Madam Chair, members of the committee. Again, my name is Mark Johnston. I'm from Sioux Falls, South Dakota. And I'm here to share with you some information about how Avel eCare is helping patients and the state of South Dakota improve access to care, conserve resources, and reduce involuntary committals. Next slide, please. Just a quick snapshot. Our organization has been in business for 30 years. We were born out of a not-for-profit healthcare system based in South Dakota that served hospitals in South Dakota, North Dakota, Minnesota, Iowa, and Nebraska. Today, we are no longer a part of that not-for-profit health system. We're a private company, and we have grown to more than 650 hospitals across 32 states, including 29 hospitals here in the state of Kansas. We have been serving Kansans since for about a decade with a myriad of services from emergency care and pharmacy to behavioral health, from Atkinson to Goodland to Larned and Great Bend. So there's a number of wide geographic dispersion. Next slide, please. Just a little bit about us. We have a variety of services that we provide to hospitals and health systems and governments throughout the country. We started in 1993 and doing before the internet was really a thing with telephone virtual consultations for specialty services, and that has grown to where we now do remote patient monitoring for ICU beds throughout the country, to the newest innovation that we're partnering with the state of South Dakota on, where we're putting the same emergency services that we support Kansas hospitals. We're putting that in the back of ambulances in South Dakota throughout the state to improve pre-hospital care and helping with the workforce. But the reason I'm here is to talk about a service that started a few years ago called crisis care. I don't need to regurgitate the mental health care crisis because it sounds like that's been pretty well established over the last few days and the last few years. Next slide. But what we do as a telemedicine company, and I should mention, we are a Joint Commission accredited virtual hospital. We were the first one in the United States, and now there's only two, but it's the same governing body that does accreditation for hospitals throughout Kansas, but we just happen to be a virtual hospital based in South Dakota. And from a crisis care, from a mental health perspective, we are working way upstream in the process. So like crisis care, which we're providing in support of law enforcement throughout the state of South Dakota and Nevada. We're doing school health, where we're providing virtual school nurses throughout the country. We do emergency rooms in 27 hospitals in Kansas, as well as outpatient and inpatient mental health support. So when it comes to the law enforcement, we've all spent an inordinate amount of money investing into 988. But what we are really finding, we're still 911 continues to be the first call to crisis. And I'm going to give you three numbers to think about: 20, 50, and 80. And the first number, 20, that in the state of Kansas, the state of South Dakota, and it's a nationwide survey, 20% of all the calls that law enforcement respond to involve a mental health crisis. 20%. Next slide. So crisis care started 3 years ago in the state of South Dakota. The Chief Justice of the South Dakota Supreme Court came to us with a problem that way too many of our citizens were ending up in court instead of getting the mental health care they needed. And so what started as a 15-county demonstration project over 2 years that was administered by the judicial branch has now become a nearly 50-county operational program within the executive branch of government, within the Department of Social Services Office of Behavioral Health, where we are providing the technology, the equipment, and the professional talent that rides along with law enforcement on every shift within the counties to provide on-scene and real-time mental health services. Last summer, we expanded to the state of Nevada, where we're supporting 13 of their 17 counties. We started supporting university, campus police. We're finding that a lot of campus behavioral health offices are 8 to 5 Monday through Friday, and we know on college campuses it's a 24-hour operation, and so we're growing in that space. And in 2023, earlier this year, the University of Iowa Rural Telemedicine Research Center released a study, which I'll provide the link to that study for your review, Madam Chair and Committee, to just about the efficiency and effectiveness of how crisis care helps with on-scene behavioral health assessments. Next slide. Really how it works. It's as simple as when a law enforcement officer receives a call, he or she they activate with us, and within seconds, our trained and licensed behavioral health assessment nurse gets on either an iPad or a phone that's provided by the law enforcement officer, and that nurse does a de-escalation assessment, an assessment on the individual through de-escalation, through safety plans, and making sure that that person is safe. And so in our experience, that number 50 of all the calls, of the hundreds of calls that we've fielded over the last 3 years, 50% of those calls involved suicidal ideation or self-harm. So 20% of the calls that law enforcement respond to have a mental health nexus. In our experience, 50% of the calls that we respond to have some suicidal ideation to them. And yet, 80% of the time, when our assessment nurses do that on-scene and real-time assessment, whether it's on the front porch, in a vehicle, in a tractor, or wherever that person in crisis is, 80% of the time, we're able to de-escalate the situation, make sure they're safe, and then the key part of our strategy is we partner with local resources in an outpatient setting and do that warm handoff, maybe to your community, whatever your acronym is today, community mental health centers. They're partners. And so, yeah, 80% of the time we're able to divert patients away from jail, an emergency room, or our version, Larned. Ours is Yankton, South Dakota, but we're able to divert those patients away from the places where they really don't need to be and get them the care in the community in an outpatient setting. Next slide. Just, you're gonna have copies of this presentation, of course, but just the difference and as we're continuing to grow with this initiative, we're finding that it's a tremendous value for local units of government, either at the city, county, or even at the state level. I heard Representative Blex, I think it was you, or that talked about the local impact, but we're making a huge impact on local budgets by diverting people away from the highest levels of care, or in some cases, no level of care. We also have a number of our partners in the counties that are using us in the jail because, again, like the universities, a lot of the mental health resources that service jails are 8 to 5 Monday through Friday, but what happens after hours and on weekends? And even in some of our largest communities, we have become that in-jail mental health assessment tool for them. Next slide. We are proving every single day that we're limiting holds, fewer transfers, saving costs, and most importantly, reducing the stigma of patients in mental health crisis. I failed to mention earlier, we talked about the numbers, but one of the most impactful numbers from the time a law enforcement officer calls our crisis center to activate that trained and licensed behavioral health nurse to the time when he or she has a report of disposition on the person in crisis is 42 minutes. 42 minutes. Not hours, not days, 42 minutes. And it's, and I understand, and one of the reasons I'm here today is because of the number of customers that we have in the state. We've established a good working relationship, and behavioral health continues to be a topic where they need assistance. And so I wanted to come down today to share information about how we're impacting crisis care way further upstream in the process. Last slide, please. So, as I mentioned, the University of Iowa. This is peer-reviewed, published data from the University of Iowa that took a look at the system that we designed and developed in South Dakota. And they took a snapshot of the data. And like I said, this started out in the judiciary branch and is now flipped into the legislative branch. And we're continuing to grow. We're now even going into tribal communities, partnering with tribal governments to provide this service and access to patients in crisis. Next slide. And a couple, it's always good when you have good people saying good things about other good people. And so two of our sheriff partners talk about the impact that this has had on their life as a senior law enforcement officer in the county. And I was actually talking to a friend of mine that's a sheriff recently from central South Dakota, and he was telling me about this has impacted him so much in his county that he has virtually eliminated involuntary commitments into the state system because we're able to help him with this diversionary tool to help his citizens in crisis. And so with that, Ms. Elizabeth told me I had 10 minutes, so I'll stand down, Madam Chair, and stand by for questions.
She is a taskmaster, I'm
Yes,
just
ma'am.
saying. Thank you so much, Mark, and thank you for staying within the time frame. Committee, do we have questions for Mark before we move ahead? Representative Carpenter.
Thank you, Madam Chair. Thank you for being here. So you have, it's kind of I'm not always about the money, but you touched on savings.
Yes, sir.
So have you been in this long enough to even put a number to the type of savings you're talking about versus, the offsetting the capital investment?
Yes, sir. Madam Chair. Representative, it's, I'll just, in general terms, we're seeing approximately a 5-to-1 return on investment. We're diverting costs 5 times higher than the state of South Dakota is having to invest.
And just to follow up, so
Yes,
you
sir.
have a report that you could give us a link to that would detail out, your savings and kind of how it went. I can see the better care, and no doubt. I'm just trying to get my arms around something.
Yes, Representative, Madam Chair. So our model is a little bit different. We don't do any direct-to-patient billing. we partner, like our partners are the state of South Dakota, Department of Social Services, Office of Behavioral Health, as well as the state of Nevada Department of Health and Human Services. And so it's like a subscription service. We contract directly with the state, and then the state is providing the service to the counties. And then we work as we do implementations and reporting, that is directly with the state. And so, Representative, what I could do is work with my colleague or my counterpart within the Department of Social Services to come up with that type of a number for you.
Well, I don't mean to put you on the spot,
No.
but I'm telling you right now that my comrades up here on the floor aren't going to go, well, this guy said we saved 5 to 1.
Yes, sir.
You know, I'm just
Oh,
looking
I
for.
totally get you. And in full transparency, I used to sit where you sit.
Okay, well, very good.
I've been there. And I'm a former state senator in South Dakota and former governor's press secretary. And when that governor decided to be a U.S. senator, I was his D.C. chief of staff. So I've sat in the seats you have. And I understand where you come from, sir.
Okay, very good. Thank you.
Madam Chair.
I would just like to give you a scenario. So I don't know how much you heard of yesterday or today. I know you were traveling in from South Dakota. But we have the Net 988 system. So the way it works currently is we have call centers that take those calls. So those are routed directly from it could be from the sheriff's department, could be from law enforcement. This person came in or we apprehended this person. Or it could just be the person calls in, or maybe a doctor says you should talk to this person. So then we have the MHIT program or the MHIT program where we have mental health in schools.
Yes, ma'am.
So I'm trying to figure out where you would fit.
Yes, ma'am.
Could you help me with that?
Yeah, thank you, Madam Chair. Thank you for the question. I think it would be integrated into that further upstream. Now, South Dakota, we're a very rural state. We're about a third of the population of the state of Kansas, and there are holes, there are gaps, and I really see us being a gap coverage and being a partner with 988, being a partner with the community mental health centers, and because going back, it is part of our workflow to hand that patient off at the end of the assessment to local resources, whether it's county, city, state, public, private, whatever. And I kind of look at us like gap coverage for insurance. We're here to fill the gaps. And that's how I see us filling, or potentially supporting the state of Kansas and the hospitals we serve.
So then you would say, because I see on one of your slides, you said you have 29 partner hospitals in Kansas.
Yes, ma'am.
So then it's a subscription service. So the subscriber could be someone could subscribe, a county could subscribe to your services. A rural county feels like they would like to have, am I understanding this correctly?
Yes, ma'am.
Okay. Committee, do we have other questions for Mark? Yes, Representative Blacks.
Okay, thank you for being here, and thank you, Madam Chair. Could you clarify the fact that in the state of South Dakota or even in Nevada, is those telemedicine services available for collection? And let's assume a person is eligible for Medicaid or Medicare, then does the state of South Dakota, you have a subscription service,
Yes.
so you don't have to mess with any collection material like a community health care center would. So does the state of South Dakota or Nevada have to fill out claims with CMS to get those ones that might be eligible for Medicare or Medicaid?
They are eligible, they could. It doesn't say they will or do, but they could.
Is South Dakota doing it?
In some cases, the counties are,
Because,
where the person's at.
yeah, because our clinics have that billing cost, and your company would not.
Yes, sir.
So you'd be clean to just cut a check for a monthly subscription service and then, but trying to figure out if there's a way to recoup the cost from the federal end of that too.
Yes, sir.
So, thank you for that.
Yes, sir. Madam Chair.
Do we have additional questions, committee? Representative Landwehr.
So basically, if I understand it correctly, basically what you're doing primarily is for law enforcement dealing with an individual in crisis. Is that correct?
Mostly, yes, ma'am. Excuse me, Madam Chair. It goes across multiple access points. Yes, we're supporting law enforcement, but then we're also, school resource officers are using the tool. We have some municipalities that are using it to, even within their own county, mental health officer, Office of Behavioral Health, the court services offices have our technology in their offices when they encounter citizens in crisis. So they're using the tool in many different forms, but yes, Representative, the main focus is on county and city police.
Madam Chair, the reason I ask that is because I know that, as we were working through the CCBHC legislation, and I visited with Missouri, they actually have tablets with, law enforcement is carrying them around. So if they come across an individual that they've stopped or encountered, they're able to hand that to them immediately. And that ties back with the CCBHC. So there's a lot of different types of systems out there. Thank you.
It's similar, very similar, other than the fact that our provider on the other end is a licensed mental health nurse.
Well, I'm sorry, Madam Chair. These are licensed individuals. These are not just someone answering a 988 call. These are licensed individuals because they're within the CCBHC and they're designated to handle those crisis calls. And it's almost like what we have in place, I'm sure a lot of other communities do, is where you may have calls that a law enforcement officer and a social worker go out on, together physically. But this here actually just gives it. Because one thing I always caution people on is don't look at telehealth as being the cure-all for the workforce shortage, because you cannot treat these individuals just with that. Think about the screen time. You've got to have the in-person. And with counseling, it is very important for that therapist, counselor, whatever the designation is, to see body language, whether it's the foot tapping, it's the movement of the hands, or different little things out there. So telehealth isn't the be-all when it comes to, I think, any health care. It is a tool to be used in it, but not necessarily to provide all the treatment. Thank you.
Madam Chair.
As you said, it was a gap provider. Thank you so much for being here with us today.
Thank you for the opportunity.
Committee, before we move on to our next speaker, Representative Ballard had a question for Sonia, if you could come back up to the microphone.
Thank you, Madam Chair, and I'm sorry I didn't think of this before. You were talking about the federally qualified health centers, and I think we indicated 22 is what I saw, I think, on the chart.
Yes.
How are those hospitals chosen?
How are the federally qualified health centers chosen?
And how do we decide where they're going to be, basically?
Madam Chair, Committee, and Representative Ballard, actually, federally qualified health centers get their designation federally, and that decision is made generally coming from the community. Most of the health centers that are in existence today were either free or community clinics or new or practices that evolved into lookalikes and or federally qualified health centers. But those are generally, it's based on community need. It's not set through the state or county. Now, sometimes it is a state or county or even a federal agency or organization or community group that approaches a community clinic or other entity to say, we really need more services in our area. Many were started that way as well.
And they're geographically located, or it's just basic what you say, a community decides they want it, and you take it from there?
Right. It basically comes out of community need. So when there's a community need, you know, again, you may have a free or low-cost clinic, charitable clinic that is operating. And one example of that is Mercy and Truth in Kansas City. Mercy and Truth was a charitable clinic, free, low cost, for pretty much only uninsured patients. A few years ago, they started working on their putting together their plans to become a lookalike and then eventually an FQHC. And they got the lookalike status last year. And again, if there's a new access point or a expansion grant that comes out from the federal government, then they could apply to get the actual funding as well. But so that's one example. There have even been some private practices who have evolved into FQHCs. Sometimes it's through acquisition, sometimes it is through them making a decision that when the next service area competition is available, that they will apply for funding.
Thank you. I realized when you were about to sit down, I thought, wait a minute, I don't think I've ever gotten down to how they really established. So that was good.
Absolutely.
Thank you so very much.
You're welcome.
Thank you, Madam
Chair.
Sonia, if you don't mind. So if I understand this from what you just said, the federally qualified community health centers that is a designation. Is that
Yes.
they applied for that designation?
Yes, Madam
So
Chair.
we had heard that there were few, if none, federally qualified that applied for the I always get it wrong, so I have to look down, CCBHC designation. So might they be applying for that next year, or do you know?
So our understanding of the way that our legislation and the establishment of CCBHCs in Kansas has happened in a way that the community mental health centers must first get their designations before others are allowed to apply. And so we do know that there is at least one, possibly others, that might apply at the time that we are allowed to, so to speak.
Thank you very much. And committee, we're going to go to our next speaker, which is Aaron Biter. And Tara. And Tara, is that last name pronounced Chetier?
Chetier.
Okay, and you are with the Kansas section of American College of Obstetricians and Gynecologists.
Yes, thank you, Madam Chair.
Thank you.
So thank you very much for having us. I'm Erin Biter. I'm a perinatal psychiatrist. So I see women who are pregnant or within the first year postpartum with mental health concerns. I also serve on the Maternal Mortality Review Committee for the state of Kansas, and then I staff the perinatal access line that we have in the state as well. Thank you so much for having us. My name is Tara Chetiar. I'm an OBGYN with a certification in perinatal mental health. I also serve on as the chair for the Kansas Maternal Mortality Review Committee, and I also staff the perinatal mental health access line for the state of Kansas.
Ladies, what I'm going to have you do when you're speaking is that will kind of swivel the base. If you want to just swivel the base, to each other. We can hear you okay, but the people on WebEx cannot unless you're really close to that mic. Okay, thank you.
Thank you. So just to be very clear, we want to make it known that we are not here representing our employer. We are just here as physicians to speak with you. That's it. So just to kind of be clear on what we're talking about. So for perinatal, we are talking about either during a pregnancy or within the first year after that pregnancy has ended. And then for mental health, we're talking about anything from depression, anxiety, OCD, bipolar disorders, psychotic disorders, and substance use disorders as well. So we wanted to address who really perinatal mental health affects. About 85% of women in the U.S. will experience at least one pregnancy by age 44, and 1 in 5 women will experience a perinatal mood or anxiety disorder.
There's multiple risk factors, but these include history of mental health disorders, pregnancy complications, infertility or difficulty conceiving, current or previous trauma, financial or other social stressors, and unplanned pregnancies. We really see an interesting kind of dichotomy, both from the absolute most desired, we worked so hard to get pregnant kind of patients, to the this was not at all in the plans and I don't know what to do and I'm scared, and we see a lot of mental health disorders on both ends of those spectrums.
So one of the reasons that I really love taking care of this patient population is because it's a really cool opportunity to, should I get really close to this, to affect the mental health, not only of the mom, but also of the child. And really, we get to make a really big impact on the entire family unit, which is kind of a unique period of time. Sorry, I thought you were going to ask me something. Are we good? Okay. So there are impacts on both mom and baby when we're looking at this kind of period of time. So in terms of the pregnancy, we see more pregnancy complications when there is an impact from mental health on the pregnancy. So these women are less likely to engage in regular prenatal care. They're more likely to have nutritional difficulties, and that can include both overeating and undereating. And so we see kind of the impacts on the pregnancy from both sides of that. They're more likely to use substances while pregnant, and that does include, nicotine and alcohol use as well as illicit substances. Those babies are more likely to be small, which has developmental implications for them, and they're more likely to be born early, which of course has developmental implications as well. And then, in the worst case scenario, mom actually could attempt or complete suicide during pregnancy if mental health is untreated, which of course would be devastating for everyone. In terms of the babies themselves, we see that when mom's mental health symptoms are not treated, they are more likely to have difficulty bonding with baby during that postpartum period, which leads to more difficulties with breastfeeding. Those kiddos actually start to show changes in developmental milestones by the time they're about 18 months old. And we see that kind of progress to an increased risk for mental health symptoms in those kids as they reach adolescence and then into adulthood. So we really see very long-lasting impacts for both mom, baby, the whole family really, when these disorders go untreated.
And when we think about how this affects us as a community, we really see perinatal mental health disorders as a major cause of maternal morbidity and mortality. Perinatal mental health disorders are the #1 underlying cause of pregnancy-related death, both in the United States and in Kansas. The estimated cost to us as a society of untreated mental health disorders in pregnancy or postpartum are about $14.2 billion. That's from the CDC. And substance use disorders contributed to about 26% of the perinatal deaths just in our state of Kansas. So this is a health crisis. I know we've talked about it in a lot of broad areas, but in our specific patient population.
So some of the things that Dr. Chediar and I see in our practice are a really limited access to care in the state. So many of our patients have trouble finding therapists who can take their insurance or who are able to see them in a timely fashion. One of the things about pregnancy that's both a blessing and a curse is that it's very time limited, and so it can be difficult to get that intervention to patients during the time that they really need it. We see difficulty in finding mental health providers and obstetricians, gynecologists who are comfortable with managing mental health conditions in pregnancy. So one of the ways that we could make the biggest impact for our state is really improving education to those providers who are taking care of these women already, because we don't have enough specialists to see everybody, but helping family medicine doctors, obstetricians who are practicing in rural areas be more familiar with how to manage these conditions when they do come up in pregnancy would really help improve the outcomes for our state. We also see that women who are unable to take time off after babies are born tend to have higher rates of depression. They're also much less likely to return to the workforce and certainly less likely to return full-time after having that baby. And in the United States, the average woman has to go back to work after about 2 weeks postpartum, which is a pretty significant hardship for that bonding and that ability for mom and baby to connect after babies are born.
Thank you very much for your time. We really just wanted to raise awareness and be here to answer any questions you have. We really appreciate it.
Thank you so much for being here. Committee, do we have questions? Representative Ballard.
A lot of times when you talk about the depression, it doesn't show itself up like right away or anything like that. And I'll use an example of Serena Williams as an example. I mean, very healthy, athletically, you name everything. And yet she had all kind of clots and she almost died in childbirth. And most people think childbirth is simple. And yet, you know, it really is not simple. It's probably one of the most dangerous things you actually could do. But people think because it comes out normal all the time, it's okay. Could you comment on that, please?
Absolutely. Thank you, Representative and Madam Chairwoman. What we are seeing is as more and more data comes out about this, that it's not that it doesn't show up, but it's that we don't look for it. Most of our patients who, when we do big studies on depression and anxiety in pregnancy, will have symptoms that actually were present pre-delivery, and about a third of them are actually even pre-pregnancy. It's that we're not screening for it as much. And there is, I think, a large societal pressure to make this the happiest time of your life and to be Superwoman. You can be a Wimbledon winner and also have a baby and get right back to it. And so there's definitely a stigma of this is weakness in the area of Instagram and I'm doing all the things at once. So there's actually been a big national movement from ACOG, the American College of Obstetrics and Gynecology, to improve our screening, including doing it at the first OB visit, so that we can catch people, hey, are you already depressed and we're going to put you through this really stressful pregnancy, and then do it again during the pregnancy, and then obviously screening at postpartum, which has been really the traditional method, because we think up to about 60% of these mental health disorders were probably present at least during the pregnancy, if not before.
I think you also brought up a good point that a lot of what tends to trigger some of this for women is how vastly different the experience is from their expectations. So you talk about somebody who's super healthy and athletic and has all of this, you know, perfect life going for them. And this is not the experience that she expected to have, right? If anybody was in a good place going into delivery, it was Serena Williams. And so part of what we see as important is helping the care team be set up to recognize when are these people actually going to be at risk, right? You see a delivery experience like that, that's so vastly different from what we expect that to look like. And that is somebody who needs to be monitored much more closely compared to somebody who everything goes smoothly as expected.
Representative Carpenter.
Thank you, Madam Chair. I'm probably not an expert on this subject and never will be, but I just wanted to go down your list on your last slide, improve access to care. So pretty much up here, I think we had at CanCare, 40% of the births in the state of Kansas are Medicaid. So that's kind of in our bailiwick here. So improve access to care in the Medicaid side. So last year we passed 12-month postpartum care. We also have presumed eligibility for any pregnant woman that walks into a doctor. So can you build on that about what you're talking about when you're talking about?
So our obstetric access to care is good. I think most people can get in for pregnancy-related care. The place that we see the hardest access to care is with the mental health services. Most therapists do not accept Medicaid, and they don't really have to. They can have a cash-only practice and make lots of money doing it that way. And so a lot of those 40% of patients have no way to get therapy.
But we just had 2 days of almost of our CCBHCs taking care of that kind of situation. So is that an issue? I'm just trying to understand.
What we're generally seeing is that if patients are not able to pay several $100s out of pocket per week for therapy, that they're not able to get an appointment for 6+ months, which at that point, they're well past kind of this critical period. The other thing that ends up coming up a lot, I would say at least half of the people that come into my clinic had some kind of services and were taken off of their medications because they became pregnant and then had a mental health crisis. So I think a lot of it is again, the people who they do have access to, which maybe is more their OBGYNs than people like me, being comfortable and actually knowing how to provide mental health treatment. As far as I know, I could be wrong, there are 2 other physicians, psychiatrists in the area who have special training in perinatal mental health besides me, and neither one of them takes insurance. So that's kind of what we have for the state right now.
Thank you for that. Unfortunately, our folks have already left that could probably answer some of these questions for me, but we just had 2 days of hearing, and we feel, at least from what the testimony that I heard, that it's not an income type of situation in our mental health facilities. And so I don't know. I'm just trying to figure out if it's an information.
Thank you so much, Representative. I would say it is more the outpatient therapy side is where we're struggling. For most of our patients, this is not inpatient, this is not IOPs, these are not patients that need partial hospitalization or anything like this. This is just, hey, I had a baby and I have terrible postpartum depression. I want to talk to somebody about it that's not my husband who thinks I should be doing better, and why am I not overjoyed about this? And the list of therapists that we have that they can afford is very small, and the ones that they can or that take Medicaid, again, as Dr. Biter said, really have a long wait list because they see in all of that, and by the time that you get someone postpartum into them, they're not postpartum anymore.
Well, thank you for that, but there still must be a disconnect between the testimony that we had from our FQHCs, which provide walk-in mental health services, our CCBHCs. So I'd like to follow up more on that. Am I off track here?
No, I think you're on track.
Yeah, I think another part of what we run into is that women who are either pregnant or postpartum are often told, I'm not familiar with this, I'm not comfortable with this, I don't know how to help you. Or they get some of what Dr. Chedier has alluded to, which is, I don't understand what the problem is, or this will get better within the next 6 months. Once your baby starts sleeping through the night, you'll be fine, like just tough it out. Unfortunately is the feedback that I've gotten from patients who have gone to folks who don't have additional training in postpartum mental health.
Well, thank you for that, but committee, maybe at CanCare, the next CanCare, could we dive into, I mean, I'm under the impression just from sitting here that these kind of services are available. And so you're totally, we just finished all this hearing, and so this is totally catching me off guard. Reimbursement for therapy and social services. I'm just trying to get my arms around what we can do and what we haven't been doing and where the disconnect is on what you're talking about.
Thank you so much. We very much appreciate your engagement. We are not policy wonks, so all we can do is tell you the experience we have as the physicians here is that our patients come back and say, I called every name on your list and none of them could get me in.
That was going to be my question. So women come in and which one is Erin? And you are the psychiatrist and you specialize in perinatal.
Yes.
Interesting. So of course there aren't very many of you, I would guess. So what you do now is someone comes to you as a gynecologist and they're pregnant and they're experiencing depression or afterwards, and you said, I called everyone on your list. So basically you say, here is some list of mental health services that you can go to. And they said, I called everybody. Is that what I'm hearing you say? Thank you. Senator McGinn, did you have a question?
Well, I was just trying to help out Representative Carpenter. I can do it plain English out in the hallway, but anyway.
That's fine.
I think they've made some very good points that I picked up on. And one is, we're not looking for the problem, and it quite often could start before the child is even delivered because their whole body's gone through a whole bunch of hormone changes already. And then the other is people typically, back to why don't they just walk in a door? Typically, they're told at home, you should be happy. I don't know what's wrong with you. You should be happy. You just had a beautiful baby. And so I think that there needs to be a little bit of education and encouragement. I happen to know somebody who took their life and came from a beautiful, perfect family with lots of support, and it was just a shock to the whole community because nobody knew she was in trouble. And so I just think there needs to be a little education behind it because I don't think people totally know that that is a real deal out there in the world. And it's not just like my teenage daughter, she's been depressed for several weeks. I think I'll take her in. That's a whole different scenario than somebody who's getting ready to have a baby and has a baby. And now their whole body's changing again. So.
Thank you so much, Senator McGinn. That's exactly right. And the other thing that sometimes impacts us is once you do have a baby, you have to bring that baby with you lots of places. So when we think about the just walking through the door, if for anyone who's had a baby, getting out the door is very difficult sometimes. And then how long are you going to wait? And do you have enough diapers? And are you going to breastfeed in the middle of the waiting room at the health clinic? And how all those things go, it can be really overwhelming for new moms.
Representative Landwehr.
Thank you, Madam Chair. And I did notice that Kyle with our CMHCs did come back in the door, so we might bring him up and discuss with him from a CMHC perspective. I would also say that we put in funding in for expansion of our pregnancy resource centers, and I think that that's something that we need to visit with them, and as that grows, because that could be another resource for us to put people into, because that's supposed to help them before and at least 2 years after. So you're familiar with those centers, kind of? You were nodding.
Marginally, yes.
Right, okay. So I think that would be another resource for us to take and expand on as that comes on board, because I understand the RFP went out. I just don't know where the RFP process is. Can we have Kyle come back up at some point, Madam Chair?
Yes, before we do that, Senator Baumgardner has a question for these ladies.
Thank you, Madam Chair. And thank you for your presentation. I was curious, does the Kansas Department of Health provide any listing for our OBGYN caregivers in the state as far as what would be reliable sources for the mental health care? And a second question, if you could just address the issue of that perinatal time, the most dangerous or the most common cause of death of a pregnant woman is that someone has taken their life. And so could you talk about interventions that are being provided for pregnant women that might have an abusive partner?
I will start with, I'm not sure if there is a specific list of providers that, through KDHE, that do perinatal mental health other than us, through KCC.
Yeah, that's what I was going to say. The Kansas Connecting Communities, which is the perinatal access line, we do have a resource and referral specialist who keeps a list that she is able to help connect people depending on what the resources are that they need. And this is not an official thing through KDHE, but the Postpartum Support International website also has a list of people who have done a certification through Postpartum Support International that's searchable by region. Again, most of the people that I know that are on that list don't accept any insurance. But it is a searchable place to look for things. What was the other question?
Resources for suicidal.
Oh, for intimate partner violence, right? That was the question. Yeah. So, could you ask the question again, please?
I'm happy to. Just was wondering, are there any specific guidelines for the OBGYNs in those prenatal meetings to, or appointments as far as screening to make sure that they know what resources are available to them?
Absolutely. Screening for intimate partner violence is a part of routine obstetric care. It should be done at every first OB visit, and then subsequently if there's any concerns. It is, of course, always challenging to screen for intimate partner violence, and it's especially so in an obstetric visit because frequently partners come with because they're there to see the baby too, and they want to be a part of it. And so that does sometimes get challenging. Most OBGYNs have some sort of system in which they can get their patients some privacy in order to they put signs up. Some of them will put different colored pens in to write on the urine sample, like if you're in trouble, write your name in red instead of in black, and some, we'll find a way to talk to you separately. There's always a lot of handouts in bathrooms and things like that, but it is considered part of routine obstetric care. And then as far as resources go, it's very community based on what resources you have for intimate partner violence.
I know since Dr. Chetty and I have been working together, every now and then we run into situations where the solution that we have is just to admit somebody to the hospital, and the OBs help us find a good reason to just have someone in the hospital until we can kind of sort through what they need. And interviewing the patient separately is a routine part of the psychiatric intake as well. So we would always have at least part of that visit be alone.
Doctors, thank you both for being here today. And Kyle, if you could come up for just a moment, please, and address this question, and then we'll move on to our committee comments and recommendations.
Thank you, Madam Chair. Kyle Kessler with the Association of Community Mental Health Centers again, and I think I've caught up with about 9 text messages that have me educated a little bit. And some of the feedback I received was absolutely if we could get on the referrals list, the local CMHCs or CCBHCs, then they can be a resource. And most are now offering same-day access with at least a 10-day connector for therapy services. Sorry.
So you will be able to visit with these lovely
Yeah, I will absolutely exchange
doctors
contact
and-
information with them.
This sounds great. Thank you so much for coming back into the committee room.
Thank you.
Committee, thank you, ladies, very much. Committee, at this time, we are going to turn our attention to any comments and recommendations based upon our 2 days of the testimonies that we heard. Who would like to go first? Well, I'll start with one. Based upon what we just heard, I think one recommendation would be that we have KDHE report on resources for mental health services available to physicians who provide pre- and postnatal care. Other recommendations, and I realize we're diving right into this, so I'll give you just a couple minutes to think about it. And to clarify, the question was asked of me, are these recommendations to come back to Bethel in October? And the answers are yes. Senator Baumgardner, do you have a recommendation?
Yes, Madam Chair. What we did here yesterday is there's absolutely some confusion as far as identifying foster kids when they're entering into a school. And It seems as if the contractors don't know who the liaison is. I'm talking specifically about the 90 schools, the 90 MHIT schools. And so we could start with them and spread out to the rest of the school districts, but it seems as if there is a real disconnect. So those kids aren't receiving those services because folks in the school district don't seem to necessarily know who those foster kids are coming in. So some clarification about our liaisons and contact information, getting to all of the caseworkers in the all the caseworkers in that catchment area. Thank you, Madam Chair.
Representative Landwehr.
I think to tag along with where Senator Baumgartner is going is that we make it a point in our discussion for the Secretary of DCF to present to us what she's got in place, has planned for being in place, or whatever to resolve this issue.
Senator McGinn.
Thank you. Wasn't there an issue yesterday, though, that had to do with not all kids that are being served are being counted? So if they're going through the liaison side and getting services versus going through the HQAC side, we're not getting a total accurate count of who's getting served in our schools. Thought that was in yesterday afternoon's conversation. And
If I could address that, yes, it was. And the question became, if the liaison, who is paid for by the state, is sending, partially paid for by the state, is sending a referral to a non-CCB, I always say it wrong, MHIT provider, thank you. The MHIT provider, then they should be counted. But as was stated from the FQHC, that they said not all of the referrals are coming through the liaison. It was a small number. So that's basically a private entity. That's not part of, yes, the school itself has negotiated with them, but it's not something that the state is a part of, negotiating with them.
so we don't have to exactly know what the diagnosis is, but do
No.
we want to know how many children are being served for any kind of a mental health?
And in what way? I would have no problem with that, and I think that, and how would you like to phrase that as far as a recommendation goes?
Well, whether it's a HQAC or some other entity that's private perhaps, that's not going through the liaison side, somehow there has to be a reporting to the school, and you have one column, here's the liaison side, and these are the children being served, and then the other entities, all they have to do is tell the school, we served 25 kids, X amount of days, and that type of thing. And some are still in progress, and some have returned to more of a normal classroom setting. I don't know.
So a reporting of data of, and what I hear you saying is not just the number of students that have received services through the MHIT program per se, but are receiving services, an additional reporting for kids that are receiving services from in-school mental health providers, whether they're through the MHIT program or not.
Right.
Okay. Did you get that, Elizabeth? She'll read that back to us about how she's doing that. And Representative Landwehr.
Well, if I can tag along onto this conversation here, I think that situation yesterday, Senator, should have been resolved had an MOU been in place between the CCBHC and the FQHC, and that didn't happen. The other thing we need to take into account, because then that would have put the kids in, because the liaison's the one that keys all that information into the online database for the MHIT program. That's how those kids are all counted, is through that online database. And there's something else I thought about. Just a minute.
While you're thinking, and it's getting late for my brain too here. I just need some understanding about, does the HQAC have to do a MOU with the CC? Does? Okay.
Well, that's what would resolve it, because if this, and part of this, has to do, I think we need to have clarification from the school, which we've asked KSDE to go back so that KSDE can explain to us how this situation happened. Did the school building, because remember, it's not districts, it's buildings. Did the building enter into an MHIT grant with KSDE? Okay, now they've got a liaison, if the answer is yes. Did they also then enter into some kind of a contractual agreement with the FQHC, which has nothing to do with MHIT? Now, had they wanted the FQHC, which is what Eric kept telling us yesterday, was that the CCB or CM, I don't know if they're a CC or a CMHC down there at Parsons. Okay. Eric alluded that the CCBHC did not have enough staff in mental health providers to serve the kids, and that is why the school district brought in the FQHC, and I struggle with that, trying to understand it and visualize it. So we have to have KSDE come and explain to us what is happening down there in that school, what kind of contractual agreements. Because I know that, like in Olathe had their own program, and then 2 years into the MHIT program, they decided they wanted some buildings to do the MHIT, but they never combined the two. Does that make sense? They never brought both providers into one building. This here, 2 providers ended up in one building, is what I understood, correct? Is that correct, Kyle? Yes.
Okay, so, ma'am.
So the school created the problem. It's not us that created the problem.
There is nothing in statute that said if you're an MHIT school that you can't do that, right?
No, and I'm not saying
Okay.
they did anything wrong. I'm
Okay.
saying,
I just wanted to clarify, because I thought that was the
Yeah,
question that Senator McGinn asked, and it was answered, yes, they cannot do that.
no.
Okay.
The school district can do whatever they want, but they're the one that chose to bring 2 providers into one building. That's where, the conflict happens. So now we can figure out, in answer to your question, how do we count those kids? The other thing you want to look at in counting kids is because you've got school staff that's licensed for mental health services that also provide mental health services for kids. So you're not getting a count on any of those kids. You don't know, are they getting outside treatment? Are they getting 24-hour treatment? Or are they only treated while they're in school?
Let me start with my end goal. My end goal is I want to know how many children are needing mental health services. And then I want to know, as we implement different programs or fund certain things, I want to know if they're getting better. And if we don't have a good number of who is getting served, we have no way to measure whether or not we're funneling money in the right place or we're providing the correct services.
Okay, and may I, Madam Chair? Yes. Well, and I think what we could do, because if I understood Sue yesterday, and maybe Kyle, you can answer this, is this is the only area that we have this occurring, correct? So we could have the FQHC provide us those numbers that they're working with. This is not a statewide issue. It's a down in the Parsons area issue. It was an isolated issue.
But we have FQACs all over the state. I mean,
We do, but
there's
they're
a map
not
in here.
But they're not being they're not necessarily being now they may be,
They
but
could
some of,
be.
they could, but they're not bringing in a MHIT and a FQHC at the same time. They're bringing in one or the other.
Yeah.
They're contracting with one or the other. I think the cleanest way to do this so that we have the online database to track these kids, if you had an opportunity yesterday to look at that, I know that you were in a water meeting. If you go back and you look at that testimony, and whose was that on? You remember, Elizabeth? No. Was that Oh, that was on John's, wasn't it? Yeah. From KSDE, that was on John's slides, if you go in there and look. And it shows the quarterly report that is pulled from the online database. So it shows, X number of kids. Did they have less tardies? Did they have less classroom disruptions? Are their grades improving? Did they graduate? Did they leave the program? And you'll find that most of them kind of stay in the program for a while. It would be nice to have those kids on that database. So it's KSDE and the CMHCs have been instructed to go back to the drawing board and let's figure that deal out. But it should be raised. It should be addressed. I agree with you on that.
If I may, before we move on from this, Senator McGinn, if this addresses part of what you were talking about, one of the recommendations that I was going to make was needing more data from the MHIT program. So what I've outlined is, and this is just part of it, I would like to see more, but for what reason are students seeking services? What's the average length of stay for services? A breakdown of how many students in each grade level are seeking services, a breakdown of students receiving services per building. Right now, all we have is we're doing a great job.
We do know by building. They have that data.
Okay?
May I ask a clarification?
Yes.
question? So for this recommendation, if I understand correctly, what you're looking for is you want to know if a building entered into an MHIT grant, if a building also retained additional services. Yes, no?
Another contractor.
Right, another contractor, non-MHIT grant. And then you want to collect some additional.
These are two different recommendations.
Okay, two different recommendations.
Yes.
Okay.
Yes.
And then on the second one, you want to collect the other information from that.
Additional data breakdown.
Okay.
I have a clarification question.
Yes.
So the original program that started, Representative Landwehr needs to listen to this. The original program that started, 6 years ago or 7? Does that fund every school that wants to be in the state of Kansas?
No, it doesn't, because it's a grant process, so they do an application with KSDE. KSDE goes through this. Now, the priority is always given to the schools that were in the program first. So if you were a building that was in the program last year, you're going to be able to get in the next year. Then they look at new buildings that want to get in. And it depends upon how much money it's going to cost. Because I think that they said they had a little bit of money left over, but it wasn't enough to fund other grants.
So if my school's in the 50 percentile, and I'm not one of the rock star schools that got to be in at the beginning, I'm not going to get in unless my number comes up.
No, it's all tied to funding. If we want to increase the funding, because they'd like to do more schools, and we have expanded the schools.
Sure, I know, but it's not equal for all in the state of Kansas. And
No, because
yes,
it's limited to
If we wanted to
funding.
increase funding, and I know what it's like when we run out of money. I've been there twice. It's
Yeah,
going to happen
I know
again.
you have. Oh, absolutely.
So I'm trying to figure out the equity for the people across the state of Kansas.
Well, and we do have it, it's scattered across the state right now, the program is. Because like there was a superintendent, and I believe he may have come from the Johnson County area, that went out to Hayes. And he asked for his buildings, some of his buildings, to be put into the MHIT program because he was a big supporter of that. So it's scattered across the state. It's advertised by the Department of Education. They let all the school districts know. Then the school districts have to decide if they want to apply. And if they apply for a grant and the money is there, they're in. It has nothing to do with about being special, but you don't want to have a building that was in the last 2 years or the last year and all of a sudden tell them they can't because a new school district across the state. Yeah, so it's not about being a rock star. It's just, if you were there, we serve you first and then we start adding. So that's why you've seen the money creep up just a little bit every year, is to be able to allow for more expansion. Because I agree, I think I'd love to see it in every school district every building that we have out there. But then again, you also have some school districts, Senator, that have their own program and had their own program prior to MHIT, and they've chosen not to change. I think Children's Mercy is one that does a lot of schools up in the Johnson County, for example. So does that help?
Yeah, Madam Chair, may I? I guess the question would be, that would answer my question is, how many schools are denied? And if there's no schools being denied, then everybody that wants to get in is getting in.
That's a KSDE question.
Yeah.
That's a good question.
Could you put that down as we need a response from KSDE? Thank you, Elizabeth. Representative Carpenter.
Thank you, Madam Chair. So just to piggyback, how much is it per school? I know we're doing 90 schools. So what is the grant? I mean, it's 75% of the teacher's salary or the liaison salary, but is it more than that? I mean, I'm just trying to figure out.
I'm not sure on those percentages. And again, it comes down per building. I think it depends upon, Kyle, did Kyle leave again?
Yes, we went out with Andy. You're right.
Okay, he heard his name. Kyle, if you'll step up, because I think you can probably answer Representative Carpenter's. Go ahead and ask him again, hon.
So do you know how much the grant is per building or per school?
MHIT.
On MHIT? I'm just trying to figure out, we're serving 90 schools, we're out of money at $10 million, you know, so, and I know the one thing that we're paying for is 75% of the liaison salary. So.
And certainly KSDE and Sue with our office would know the specifics of that better than I do. But even going back to Senator McGinn's part of the question, so far, everybody who's wanted to participate in this program has been able to. But if you look down the road at the times where they may start cutting it back or other people wanting to participate, that's when we get into a bit of a spot. But I think that the range is so much, because you were asking how many, were you asking?
Grant was, you know.
What the actual amount is.
Right, and he said he had a little bit left over for.
Yeah, and it varies so much. I mean, there are some that are like $20,000 because they may only want a half-time liaison. So the way that you would go about it is the smallest and the largest. I mean, 259 and the others have much bigger applications because they're much bigger schools. Does that help at all?
That helps a lot. I just wasn't understanding. I didn't know if it was divided equally, each person got a grant. And to piggyback on what Senator McGinn said, I think the key to this, the data that you're talking about is that they don't have access to the portal until they're a liaison or whatever. Mm-hmm. That's how we get the information, correct?
Yeah, that is correct. And that was part of the earlier conversation as well about the issue in Southeast Kansas and Parsons. The biggest difference in that is that because there's two other providers, non-CMHC providers and CMHCs that currently work together and they have a MOU between them and between the school, but there's no MOU between those two providers. So they don't report their data for that part of the program. And so others, like exactly what you just said, those who submit the data into the portal are part of that MHIT program. And there are a lot of non-MHIT school-based mental health programs out there.
Thank you.
Okay, so just to clarify, if a school is not part of the MHIT program, let's say it's Senator McGinn's school that she was referring to, if they had an FQHC, like we talked about, Dodge Elementary had Grace Med next door. If they, because my understanding from what Erica told us is FQHC, there's no charge to the school. They just said, you provide us an office and we'll come in and provide mental health services. They have no charge to the school. There's no charge to the state. They merely meet the needs of the mental health, of the child who has the mental health. they provide these services, they bill the private health insurance, they bill the Medicaid, whatever it is, for the services. And that, could they not, so couldn't Senator McGinn's school arrange something like that? They don't necessarily have to be part of the MHIT program. What am I missing?
That is actually, you asked exactly the right question, and I know an answer to it, which is when the original pilot schools and mental health centers were identified in Hutchinson, it irritated the mental health center, it irritated the school, they entered into their own program, and then they made the appropriate referrals, and then they made the appropriate billing. So I don't know enough about what the funding sources are for that FQHC. I'd be pretty surprised if they don't bill Medicaid, which is still state funded.
Oh, no, I didn't say that.
Right,
Yeah,
right, right.
they do bill Medicaid if you've got a student that has Medicaid.
Yeah.
They're going to build whatever that
But they're just not
student's
participating
services
in
are.
the.
They're not participating in the MHIT program. And what we heard them say was that they provide different services. And so they're providing this service, they're providing this service. The only issue that seemed to arise is if the liaison was being used, then that data was not coming in and being counted as part of the students, as part of the MHIT program. Am I understand that correctly?
Yeah, and I would be shocked going forward if every CCBHC doesn't want to be doing school-based mental health services, and if the school is also still able to enter that data. I think that data has been a wealth of information.
Thank you. And were you in the hall, or did you hear the 4 questions that I was asking that I said would be helpful for us to know?
I don't think so. I'm
Okay,
sorry.
let me say those again. What reasons are the students seeking help? You don't need to write it down. Elizabeth will send it to you.
Super.
But what reasons are students seeking help? This is important for us to know. Same thing with like 988 calls, et cetera. What's the average length of stay for services? How long are they needed to continue to be in the program? A breakdown of how many students in each grade level are seeking services. So then again, that data is important for us to know. And then I understand a breakdown of students receiving services per building. Now, Representative Landwehr tells me that that data was already available, perhaps in a presentation we already had that I missed.
Yeah, I think that KSDE maybe has that data. And the second question I know Sue had already started working on with the
length of
CMHC.
stay.
Yeah.
Okay, very good. Committee, other recommendations, or while we have, and I've forgotten that Senator Baumgardner has a question.
Thank you, Madam Chair, and this actually is a continuation of your comments as well as Senator McGinn's, and that is, we have lots of school districts that are entering into contracts, and several of my school districts are in contracts for mental health care services. Blue Valley School District has a contract with Children's Mercy. So when we're talking about mental health, we've spent a lot of time on 90 school districts and the liaisons in the MHIT program, but I think getting to part of what Senator McGinn was saying, and it really is valid, is of all of our school districts in the state, how many of them have some form of mental health program? What is it? Who are they contracted with? And then the 4 questions that you had indicated. Because the school districts that aren't participating in MHIT, the bottom line is the additional funding, the $13.2 million from the MHIT funding for this fiscal year, they are having to use their own funds to budget for that. So we're not getting a sense of how much total funding is going toward mental health services in our schools, how many kids are actually being served. And I think that gets to the broader issue that Senator McGinn was speaking to. What are those age groups? What are those issues that they're addressing? But quite frankly, it is that broader issue of how our different school districts are coming up with solutions to make mental health services available to students.
Thank you, Senator Baumgardner. Did you have another recommendation?
That was it, only that we would broaden it and we would get that information from the Department of Ed as far as those other school districts. And what are those agreements? You know, are they MOUs or something different? Thank you, Madam Chair.
Thank you. Representative Landwehr.
So what you're asking for, Senator Baumgardner, is for KSDE to contact the schools and see what, whether it's, like you said, whether it's just through an MOU, is it a contracted rate? And then, if I understand correctly, then is for those school districts that aren't in MHEAD, because we already know we have access to that information, is for those programs, and let's just use Children's Mercy, for example, because I know that's a big one for Blue Valley. Then Children's Mercy would have to provide us their data on the number of kids that they're serving and then answer the questions that you guys are asking for additional data on, correct?
That is correct, and I assume that the district is tracking the data as well.
I don't think they are.
And committee, are there other recommendations? Yes. Okay, Representative Ballard.
Thank you. I raised a question about the one we were talking about, TRPF. And I think you said they were monitoring the wait list when we were talking about PRTF. They were monitoring wait lists. But what I do not see in the article, we talk about we have all of these unstaffed beds. But my question would be, how many staffed beds do we actually have in the state? We know that we are unstaffed because of the workforce, but then my other half of that question, all right, but the other part of that question would be, what are we doing to increase the workforce when we know that we have, if we have any on the waiting list, how long will it take them to get off if we don't have staff beds?
Could I ask you to repeat that recommendation, make sure that Elizabeth gets it?
Okay. Not only.
So we're referring to.
Not only monitor the list, which we said we have completed
And this was number 23, and it was 5.1. We said we'd go back to that, so I'm glad you are. I had that in my notes. Okay. And so your question is, how many of the beds are staffed beds?
Yes, because in the article, it talks about the unstaffed beds due to the workforce.
Yes.
So my question would be, how many staffed beds do we have available in the state for youth?
And then you had a second part of your question.
And then the other part would be, and what are we doing to increase the workforce?
And he does have some of those answers if you want them.
Oh, there you are, Andy. Sorry, yes. If you have those answers and you want to come up, please do.
He was shaking his head, that's why.
So, Senator, we already, and Representative Ballard, we already include that information in our Bethel report. And in the weekly report that I get as the commissioner, for this week, we have a total of 298 staffed beds in the PRTF system out of a total of 402 licensed beds.
Okay, just a minute. 298 and then 492?
402.
402 licensed beds.
Yep.
Unstaffed.
So yes, the difference would be the number of unstaffed beds.
Okay, so we have our answer for those, but then.
We do, and then your section 2,
Then
your
section
second
2,
recommendation.
That, what actions are we taking, I guess I would say, to increase that? Now, my other question, since you've given me the answer, do we have a waiting list?
Yes.
Okay, that's where I want to go. So what is the waiting list?
Yeah, so the waiting list right now, as of 8/21, was 89 kids. And out of that 89, 29 were foster care kids. So the total on the wait list is 89. Out of the 89, 29 of those are foster care kids. And then total number of licensed beds is 402. And we have 279 kids that are currently in census and receiving treatment. And, in terms of, we have more than enough beds that if they were all staffed, there wouldn't be a waiting list, I guess is the point to make.
All right, so the second part of mine becomes more crucial in terms of what are we doing to recruit more? I guess because I go back when we had like 802 beds with TRI-3L. We had that many beds. And that was when people became certified and all of that. So now we've reduced down. Have we at any point had more than 89 on the waiting list? Or are we just currently at 89?
We're currently at 89 as of the 21st, but like it fluctuates. And, I think, excuse me, Representative Carpenter earlier mentioned 120. So we typically see the number fluctuate between about 90 and about 120. And I would say on average, it hovers around about 100, 106.
That's where I was going, because most of the time I see it over 100. And so therefore, what actions are being taken in order to increase the workforce? Does that mean we have to pay more an hourly, or what are we going to have to do in order to get more people so that we do not have that fluctuating waiting list?
Yeah. And I can tell you, Representative Ballard, one thing that the agency has done is when we received our ARPA dollars for our mental health block grant, we did invest about $2 million into the PRTF system in order to allow them to, do recruitment, increase salaries, provide hiring bonuses, those sorts of things. And we did see a little bit of an uptick in terms of the number of beds at that point. But, $2 million did not go very far in that system. So, I think it'd be a good idea perhaps to have some of the PRTF executive directors come and maybe talk about their hiring challenges and workforce challenges.
Elizabeth, can you make note of that for Bob Bethel? Representative Carpenter.
Just one thing to add to that, Representative Ballard and Andy knows this, primarily the beds that are unfilled, unstaffed are in the Kansas City area. Is that correct, Andy?
That's correct.
It was when we've had our discussion.
Yeah, it's still accurate.
But it's still, so it's all in the Kansas City area that we can't staff these beds, so.
Senator McGinn.
Thank you, Madam Chair. I just need some clarification. Of the beds that are filled, how many of those are foster kids?
Hang on for just a second. So right now, out of the 279, 95 of them are foster kids.
Would you repeat that?
Out of the 279 that are in census, 95 are foster care children.
Said of the 279 that are what again?
In census or currently in treatment.
So we said 298 beds, right?
Right. I want them staffed.
So there's 298 staffed beds.
Staffed beds, so.
Yep. And out of those 298 beds, 279 of them are currently full. And out of that 279, 95 are foster care kids.
So a few of those kids could be taken off the waiting list if we have some staff beds that are available.
Yeah, and they will be.
And that could be day to day.
Yep.
Do we have an average length of stay for someone in these beds? Like how often is the turnover?
I would be happy to bring some information about that's specific. But in general, I would say your average PRTF patient is in the PRTF for about 90 to 120 days.
Thank you, committee. Other questions for Andy or recommendations?
What? No, that was what, now my second one.
I'm sorry?
The first one was a two-part.
Oh,
but
gotcha.
now I have the second one.
Okay, we're ready.
All right, and I would like that we do something in terms of looking again at maternal and prenatal mental health issues. And similar to what we saw today, but I think we need to put an emphasis on it because I think for some people, when I ask the question, a lot of people, it may not show up to 2 months or 3 months later, or it may happen right away. And a lot of people don't realize that it's not like it's normal, but there is some help for that. And part of that becomes the alienation of the baby because it often is rejected in the middle of it because they don't feel very parent-like in combination. So I would like us to do something, whether we do it again at CanCare or whatever, but maybe another emphasis on that area.
So Representative Ballard, the first recommendation that I made was asking for resources for mental health services that are available to physicians who are pre and postnatal, who offer pre and postnatal care.
Yeah, well, I think it's depression and postpartum, during and after.
Okay. Do we have other recommendations, committee? Yes, Representative Carpenter.
So, 6.4, I'm sure everybody was surprised when I kept my mouth shut when we
Yes.
went over that, but the community support waiver, and I would like this committee to get on board and help with that. It's very important. We have 5,100 kids on the wait list. It's close to 11 years. A lot of us have already been on committees, and so it's redundant for some of us, but it's all hands on deck to get this passed. It's going to be about a $5 million price tag the first year, and of course, it's a couple of years out because we're applying for the waiver now. But
I'll second that one.
But anyway, I just want to get my blows in on that one because it's very important. I believe we can take half the people off the wait list.
We were, as I mentioned, we were very pleased in the IDD committee that we had asked, that was part of our recommendation, is that they search for other states, particularly Missouri, which had been done. And if you listened in, I was able to reach the assistant director of their Medicaid program in Missouri, who said he would be happy to help us expedite getting that accomplished so that we could have that community service waiver. And I think we can do it faster than 2026, which is the
Madam Chair, I
estimate.
think that if we had it on our one IDD committee and we put it on another committee, the more we talk about why we need to have it on these different ones that we've been doing, the more people realize that it is crucial.
Yeah, people get tired of hearing me talk about it, but.
That's
I'm
all right,
gonna
I'll talk about it
until we
with
get
you.
it done. And then the second one is,
Before you move on,
Okay.
so how do you want to phrase that recommendation?
just that we strongly support.
This committee
Strongly
supports
supports
the community service waiver.
Yep, community support.
Okay.
Pretty simple. Number two, just, we talked a little bit about that 8.7 competency and evaluation restoration. That's been an ongoing thing, and we're working on it. And I want to give a shout out to Scott Bruner if he's listening, because I heard from a good source that this contract that he entered into with Wheatland was a huge struggle, which he never complained. I was on to him for 2 years about that contract. Get it done, and I had no idea what he was going through. So I want to thank him for that. He reported to us at CanCare about that. But we still need to get on that. I mean, think about these counties out there that are housing these prisoners that really are our responsibility, not prisoners, but there's 163 of them on average being housed by the counties at a cost that are really our responsibility as a state, but we have no place to put them because Larned is full and we've got all kinds of staffing issues out there. And again, we're working on it as fast as we can, but I just want to keep it on the burner.
And how would you make that recommendation? Is that something that's already in here that we?
Pretty much. It'd just be
Okay.
the same recommendation, but just reinforcing the fact that,
And didn't we not have it already in progress?
well, they had written completed on it,
And which number are you referring to?
8.7.
8.7.
And we had a lengthy conversation
Yes, we
about
said we would come back to it and talk about how we would phrase it.
it still needs to be in
Yes.
progress. And
Because it says a pilot, they did do the pilot, so we would have a different recommendation that would say what?
continue to try to address the competency and evaluation issue.
And report to.
And report.
Report to the 2023, or 2024, I guess would be now,
Right.
legislature. Did you get that, Elizabeth? All right. Committee, do we have any others? Yes, Rick. Senator Holscher.
Yes, thank you. Based upon the information Wyatt shared with us, I do believe we need to take a look at firearm safety, in particular firearm storage relative to 18-year-olds and younger, because as Wyatt pointed out, when you're talking about, again, 18-year-olds and younger, 7 minutes seems to be a critical time frame in which that group acts impulsively in terms of suicidal ideation. And in other areas of the country where safe storage bills have passed, that seems to have a positive impact. So I would encourage the group to take a closer look at something along those lines.
Senator Holscher, are you phrasing that as a recommendation?
Yes, I recommend that we take a look at a safe storage bill that takes effect with under 18-year-olds, because to Representative Blex's point, I do think there's something to be said in terms of rural areas versus urban, as well as age differences.
And as far as I know, we're not making recommendations for bills necessarily. We're making recommendations for ks.de to get back to us, the Department of Education, regarding the mental health.
Yes, sorry, I meant to say that I recommend that they take a look at recommendations in that regard.
Okay.
KDAG.
KDHE?
Isn't that what she said?
I thought I heard KS, yeah.
Okay.
Yours was was that 8.2? 8.7. Okay. Okay, and then Senator Baumgardner.
Thank you, Madam Chair. We've spent a little bit of time talking about the PRTFs, but more as far as the wait list and bed space. But I have occasionally heard from families concerned about, and I can't think of a time that we've heard a presentation or heard any additional information about how often does someone go in and do a site visit, and are those always scheduled? We know in restaurants and so forth that someone from the county comes in and does an inspection. But with regard to the PRTFs, do we ever have some kind of unexpected pop-in visits just to see what are the conditions, and, to verify what's being reported as far as available beds and so forth is actually, just that spot check, if you will. So if we could get an update on that process, but also if we're not doing kind of some pop-in visits, I think that we should. And like I said, again,
Senator
I've had-
Baumgardner.
Yeah.
Andy has come up to the mic. Let's see if he can address that.
Okay.
Yeah, so Senator Baumgartner, we do have a number of different ways that we do inspections. And so first off, in our survey insert, we do licensing inspections. Anytime that there's a complaint that's been filed by either a family member or an MCO or a provider about a PRTF, that goes through DCF and then back to us. And our survey insert team will go out and do an unannounced inspection, site visit to inspect and see what's going on, and then do an investigation on that complaint. We also have a quality assurance role within my commission as BHS. So our children's services staff, they go out and do PRTF site visits that are both announced and unannounced. So we're in the facilities quite a bit to try and keep everybody honest and make sure that they're living up to their requirements the best that we can. And there are issues that come up. It's not all of these facilities are able to, operate at, 100% all the time. So when we're out there looking for things, we do oftentimes make citations and performance improvement plans for them so that they can address those issues.
I appreciate that. I think then I will modify my request. So if you're doing announced as well as unannounced, could you share just some data on these are the things that we find when we're doing announced visits, and then these are the things that we're finding when we do unannounced visits. And if you could also share kind of historically the frequency in which both tend to occur, that I would appreciate that. Thank you, Madam Chair.
Thank you. And would you repeat that recommendation?
Yes.
Senator Baumgartner?
Yes, it would be that they would share with us the frequency of announced and unannounced visits and the data of what it is that they find in their announced visits, and compare that that parallel. What are we finding as far as issues with unannounced visits?
Committee, other recommendations? All right, by my count, if I've kept the proper count, I have 10, yes. Senator Holster?
Yes, did we mention anything about any type of recommendations in regard to social media and potentially recommending, what's been implemented in other areas and had an impact as far as reducing depression and suicide rates?
I'm not sure how they can report that. I do know that I am reaching out to the Attorney General's office, and I understand that Representative Landwehr is working with KBI and asking some of the questions of them as to what they have seen or what can be done by the state of Kansas.
Madam Chair.
Okay, I just want to make sure we didn't miss that.
Yes, no, that's a good point.
Maybe could we make some statement? Oh, I'm sorry.
Representative Ballard.
Thank you, Madam Chair. Could we make some statement about that, though? I don't know as we can check everybody's social media, but maybe something to the fact that we know that social media, I won't say a contributing factor, but in terms of, we know that it plays it has an impact, especially with young people, around depression, suicide, and bullying, or something like that. I'm just trying to think if we could just make a statement about it, because we know it's so prevalent in that particular area.
Don't know that we are here to make statements today. I think we're more recommendations for what we want, data we want, information that we want to get back.
Yeah, it's not a recommendation, because nothing we can really
I
recommend.
don't think so.
Okay, I see
But
it.
thank you. I think we're all in agreement in that. All right, Elizabeth, I'm sorry you've been writing over there furiously. What we're going to do is we're going to take each of these one at a time, and if you can read us what you have and make sure the person making the recommendation is in agreement. And then we will take a vote on each one as to whether we agree as a committee that this should be a recommendation from the committee. All right, give it a shot.
Katie, thank you. KDHE, to report on resources available to physicians who provide, report, I guess, back to Bethel on resources available to physicians who provide pre or postnatal care, especially in regards to depression.
I did leave out like when they're actually pregnant, so I guess it would be
Pre, post, and during.
pre, post, and during pregnancy.
That's it. Prenatal and perinatal. Okay, prenatal, perinatal, and do you want postpartum? And postpartum. Okay.
But committee, are we all in favor? And I'm the one that made the recommendation, and that works for me. And committee, are we in favor of that? If so, say aye. Opposed? All right, move on to number 2.
I had from Senator Baumgardner, regarding the issue of who the disconnect between foster care and the MHIT liaisons, in kids coming into the school district. You had several parts of that. Is that the next topic that you had? And I'm not sure who you were assigning it to as the recommendation. Are you starting with hers? Or, because we also had Senator McGinn's, did the building enter into an MHIT grant, and did the building also retain additional services? What did you have?
And that was mine as well, so that's fine. And I think that was the, how is the foster, oh no, I'm sorry, that was, I wrote it down, but that was Senator Baumgardner, I believe. How is the foster parent or caseworker notified about the liaison in the school?
Yes, that way. So we have that. So you want those separate, the two, or do you want, is the recommendation to KSDE to provide more data on what programs are, because you've had several, you touched upon these several times. So is the recommendation to request from KSDE to provide Bethel more information about, first of all, which buildings enter into an MHIT grant, which buildings retain additional services, how much are the school districts spending on mental health services, how are they obtaining those mental health services through the MOUs or whatever.
And I guess I see that as a separate question.
Okay.
The first one, the first recommendation was, how is the foster parent or caseworker notified about the liaison? Because again, they can go from school to school, caseworker to caseworker.
And is that, do you want to know that from KSDE or do you want to know that from DCF?
Representative Landwehr.
I was thinking that we would, the thought behind it was we would have the Secretary of DCF come and present that to us, along with what she's doing to get this information to the school
Foster
districts
families.
on the
So
fosters.
it's not a recommendation.
Well, it is a recommendation is we want this information.
Right, okay.
Yeah, yes.
But it was just to give the secretary a heads up that we want her to come and give us answers at Bethel,
Okay.
not just a report.
Okay, so the request is, or the recommendation is a DCF report on how foster care or the catchment areas are being notified of who the MHIT liaisons are in a building and
The transition.
the transition of
And Senator Baumgardner,
families.
does that address your recommendation?
It does. It does.
Okay.
I mean, it's an issue for the MHIT school districts as well as the non-MHIT, but there needs to be a contact person in a district, and the contractors need to know who that is.
So committee, this is number 2. All in favor, say aye. Opposed? Ready for number 3.
Okay. And then for number 3, I had the Senator McGinn's request about, did the building enter into an MHIT grant? Did the building retain additional services? And I think you're seeking that information from KSDE as to the- and that is is similar to the one Senator Baumgartner requested later on. So do you want those two
Yes.
combined to have, you want to know the total scope of mental health services being provided, whether under MHIT
Yes.
or
And you're
or
right, those
alternative
two
programs?
pair perfectly together.
Okay. And then, and you had several, and you wanted to know the cost of those programs?
Yes. Senator Baumgartner, Senator McGann, does that address your recommendations? Senator Baumgartner?
It does.
All right. Committee, you've heard the recommendation. All in favor, say aye.
Aye.
Okay, we'll move to the next.
To clarify, that's a report back to Bethel.
Yes.
Is that a one-time report or an annual report? Or,
I think for now, we could just, yeah, we'll know. We'll decide at that time, Bob Bethel.
okay. All right, then, and then we have Senator Gossage's request about more data from KSDE regarding the MHIT program, and you had the 4 questions.
Right.
Why are students seeking services, the average length of stay, the number of students per building participating?
And per grade level.
And per grade level.
Right. And any additional data that they could share with us, because I think any of that is going to give us a better idea of how well this program is performing.
And that is only for the MHIT program.
Correct. Okay, committee, you've heard the recommendation. All in favor, say aye. Opposed? Next. You're doing a great job, Elizabeth. Mine's just a bunch of hen scratches, so.
And then I had from Representative Ballard, on the number, on 5.1, recommendation 5.1, which is the PRTFs. Well, I don't know if that's really a recommendation. You would like the KDA's recommended to have the PRTF directors come in and speak about workforce challenges, primarily in the Kansas workforce challenges, because I think he answered your questions.
He answered the first part of her question, right, Representative Ballard?
But the question should have been that
What actions are we taking to improve the workforce shortage?
the recommend was to what are we doing to get staff? Because in it says that workforce is a problem, that's why they're unstaffed. So it's the unstaffed beds that I'm looking at staffing them. And what means do they plan to use in order to attract the workforce?
So continued follow-up on the original recommendation 5.1, specifically what are PRTFs doing to fully staff, and what means are they doing to expand the workforce?
Okay. We've heard the recommendations. All in favor, say aye. Opposed? Next.
The next one I had was the community support waiver, and that the committee supports the community support waiver.
And I would say that we ask that they assist in any way that they can, with KDHE, with getting this community support waiver. It's going to help with mental health and IDD. We've heard this recommendation. All in favor, say aye. Opposed? Next.
And then this was also from Representative Carpenter regarding the original 8.7 on competency, regards to continue to monitor and report to the 2024 legislature regarding the state of the competency reviews as stated in 8.7.
So that could include what other states are doing. I mean, I'm sure that, no, we're not unique in that situation.
Mm-hmm.
And just information to try to move it forward.
And I think monitoring was the way it was written initially, and I think reporting needs to be added to that.
So I put to try to monitor and report.
Excellent.
And report to the 2024
Yeah,
legislature.
I was just concurring that, yes,
Okay.
that needed to be in there.
Okay.
And there was something to the effect from Senator Holscher regarding lock boxes. I went back to look at the KDHE presentation. I thought I remembered seeing that, and it was on page or on the slides. And one that was mentioned was that there were 947 lock boxes distributed, 2,044 gun locks distributed, and that I personally don't feel that that recommendation is necessary. But we've heard the recommendation. Do we have discussion?
Did we do Carpenter's recommendation?
If not, we'll take a vote. All, can you state how? We did not. I apologize. So on the, and would you read that one more time?
Sure. Continue to monitor competency and report to the 2024 legislature regarding the original recommendation 8.7 regarding competency, and also include in that report what other states are doing.
We've heard the recommendation. All in favor say aye. Opposed? Okay. Now, would you read the recommendation from Senator Holscher?
And I had the KDHE take a look at safe storage, firearm safe storage regarding firearm safety and storage for the under 18-year-olds.
You've heard the recommendation. Regarding Senator, and we had a separate discussion. Could you repeat that again?
Sure. That KDHE take a look at safe storage regarding firearm safety and storage for the under 18-year-olds.
You've heard the recommendation. All in favor say aye. Oh.
No.
Yes.
I don't know what that means. Look at storage. Safe storage?
I'm seeing, is she, oh, she had to leave. Okay. That, sorry.
I was
firearms are not
saying, Senator McGinn, that the KDHE reported that they distributed 947 lock boxes and 2,044 gun locks distributed. That's not a recommendation that I would support, but I will leave it up to the body. Of looking at again, storage, you said, for under 18?
I assume she was referencing like safe storage programs, programming maybe that's out there. I didn't hear her say that.
She didn't mention the word program.
So.
You said look at.
She mentioned bill, but that was.
Yeah, she mentioned a bill. But I think as far as a recommendation, yeah, and go ahead, Senator McGinn.
I mean, it sounds a little bit to me like KDHE is already somehow involved if they're issuing safety boxes and locks and things like that. There is a national organization out there, I saw at NCSL, that actually.
Can you turn your mic on?
It's on. I just need to pull it closer, sorry. there is a national organization, I saw at NCSL, that the whole thing is about safety. But getting back to what our staff, our agencies are doing without creating a new program, sounds like KDHE is already somehow involved in either calculating gun deaths or handing out safety devices and things like that, according to the report you just reminded me of, Senator Gossage. And they did share just that today.
Representative Landwehr?
Are we on a motion, Madam Chair?
We are.
So then I guess I would propose the substitute motion that we not accept this recommendation. Not accept this recommendation.
Do I hear a second?
Second.
All in favor of this, of the secondary substitute motion? Say aye.
Aye.
Opposed? The ayes have it. And do we have any other recommendations?
I had a couple more. This is from, well, yes, Senator Baumgartner's, to have KDAD's shared data on announced versus unannounced visits to PRTFs, and the data they find in each type of visit and what they are finding in the different unannounced versus announced visits at the PRTFs.
Yes, yes, okay. Committee, we've heard the recommendation. All in favor, say aye. Opposed?
Aye.
And do we have another? Senator Baumgartner, that addresses your concern, correct?
Yes, it does.
Is
Thank
she
you.
still on?
I am.
Okay, thank you.
Yeah.
Oh, you were saying aye. Gotcha.
I believe, well, I have two more. Representative Ballard, you had recommended about doing something for maternal and perinatal mental health, but I think we combined that into the first recommendation. Okay. And then I had the impact of social media that Senator Holscher stated, but I don't know that there was a recommendation for that.
Don't think that was actually a recommendation. That was a question.
That was all I had.
All right. Committee, thank you so much for your work today. We got getting you out of here about 8 minutes early. I hope you, well, I'll take care of yourselves. And I started to say have a good weekend. Yeah, and I will see you in October for Bethel. Staff, thank you very much. Elizabeth, thank you.